Not yet. Okay, we are live.
Okay. Thank you so much, Neeraj, for bringing it on live to the audience and for everyone. On behalf of Bombay Spine Society, I welcome all of you to the third quarterly clinical meeting. And like Bombay is well known for it to start before time, we hope that the academics is going to set the standards to be compared and to be unmatched forever. Today, we are going to have 8 cases being discussed by the young guns of Bombay Spine Society, who will be bringing forward the dilemmas of various common conditions of spine that we all face through on day-to-day life. And to answer the questions are being grilled the senior members of Bombay Spine Society. Just to name a few: Dr. Sudhir Srivastava sir, Dr. Samir Dalvi, Dr. Mihir Bapat, Dr. Arvind Kulkarni, and all the guns are here to answer all the questions that we are going to come through. But the limelight of the day is none other than mentor to many of us young guns from Bombay, Dr. Professor Gabriel Liu from Singapore National University Hospital. On behalf of Bombay Spine Society, I welcome you, Professor Gabriel Liu, to join us. Today, the theme of the meeting is going to be degenerative spine. Of course, we'll be having cases of different sorts as well. And to set the ball rolling, I welcome you on behalf of Bombay Spine Society and also from behalf of the whole Indian spine fraternity. May I ask Dr. Srivastava sir to please say a few words, who's the president of Bombay Spine Society, to welcome our faculty. Dr. Srivastava sir.
A very good evening to all of you. I sincerely welcome our all BSS members and the guest faculty, Professor Gabriel Liu, who is known for his accomplished work in spine, and he's a great teacher. Many of us have encountered with him, and he had come earlier also in Bombay. So a very warm welcome to you, Professor Gabriel Liu. Bombay is known for its academic activity, and all the members have contributed very nicely. We have tapped the opportunity of the Corona time, and we will be further continuing this education. Now, without wasting any much time, I will hand over the proceeding to Dr. Vishal Kundnani, our dynamic secretary. Dr.
So
Vishal.
today, thank you, Dr. Srivastava. Today we have the 3 young guns who are the conveners of the meeting: Dr. Sandeep Sharma, Dr. Sandeep Sonone, Dr. Uday Pawar, and Dr. Amit Sharma, who will be convening this meeting of clinical case discussion. And as to set the ball rolling, while we have all the senior panelists gearing up to warm up them with a case, I'm bringing the first case of the day, which is a 70-year-old female with only left leg symptoms, radicular in nature, symptoms for 5 months. Patient's MRI, I'm going to come up with soon, but the X-ray of the patient shows a degenerative spinal deformity, thoracolumbar and lumbar deformity. That's the standing full spine apilateral with coronal decompensation there. That's the lateral X-ray standing. That's the supine AP view of the patient. That's the flexion view showing a stable spine in that area. And that's the MRI axial images with a degenerative disc herniated fragment at L45, foraminal stenosis at L34 on the left side, on the right side on L12 and D12 L1 area showing some foraminal stenosis there. However, just to mention again, the symptoms are purely leg symptoms. The VAS of leg symptom is 7 on 10. The VAS of back pain is 4 on 10. Patient is disabled primarily due to leg symptoms. Walking distance is less than 10 minutes, has claudication in 10 minutes time, and the symptoms have not resolved despite conservative care. A epidural root block injection given 2 months ago only gave 30% relief. The DEXA score of this patient is -2.9. Patient is already on anti-osteoporotic medication. That's the MRI sagittal film showing multi-level disc degenerative disease. And that's the coronal MRI showing a deformity in lying position. That's the T1 axial images corroborating with findings that we just spoke about. and the T1 sagittal. With this, the case is open. May I call upon the senior guns like Dr. Sameer Dalvi. Dr. Dalvi, so what is your approach to this case? Dr. Sandeep, Uday and Amit are going to be grilling you on this case and many other questions on the same lines. Over to you. Dr. Sameer Dalvi, your first question. What is your approach to manage these patients?
I think it's very important to get a general evaluation of what it is that this patient has come for. So there are two different things in this patient. One is the clinical syndrome and the other thing is the imaging features. These are two different things. And the question is, are these matching? Are these matching? So are these structural issues responsible for the clinical syndrome? So obviously what stares you in the face from the x-rays is that she has a deformity. She obviously has a spine which in both AP and lateral x-rays is not what we like to call a balanced spine. Neither does she have a coronal balance, and sagittally as well, she doesn't have a good lumbar lordosis and all of that. But to grill it down, what she actually has, what she has come to you with and come to you for is leg pain. Now here a lot comes with surgeon philosophy as well as patient demands and desires. And a 70-year-old from India of Mumbai may not be the same as 70-year-old from Rajasthan, and may not be same as a 70-year-old from Singapore, and definitely may not be the same as a 70-year-old from Japan, right? I mean, a 70-year-old from Japan would be like a spring chicken. If you ask me personally in this case, without going through all this, you have to decide, do I want to only treat the root and give her relief of leg pain for varying amounts of time and treat the rest of the spine conservatively? Or do I want to go the whole hog and treat the deformity as well? To my mind, taking the second approach of treating the whole spine and the deformity has so many pitfalls and so many complications ahead, and is such a huge procedure that I would select, because it is too much of thinking. You have to do too much of thinking in that, and you are going to go wrong no matter what thought process you follow. Therefore, I would like to treat only the root. I see that she has left-sided pain. I see that at L4-5 she has a disc fragment and significant stenosis. At L3-4 also she has stenosis. I feel that L4-5 disc is what has caused her worsening at this point in time. But since I'm going down there, what I would like to do is a left-sided nerve root decompression at L3-4 and at L4-5. I would do it with a McCulloch retractor or a tubular, and I would do same side. I would not do the contralateral because I want to see the disc. And with that, I think I would promise her, I would not promise anything, of course. I would say we are doing this surgery for your leg pain, and for the back pain, we'll see. And, treat her conservatively for the rest of the spine. So that would be my approach at this point for this patient.
So, Dr. Dalvi, what do you think that what's going to happen with her curve in the future?
So the curve may or may not decompensate. We don't have linear studies. So if you look at two scenarios for this patient, right? Scenario number one is we do only a decompression and we let the curve behave as it wants to behave. And scenario two is we select something and try to fuse, fix, and do surgeries back, fuse anterior, posterior, try to rebalance. I think her path will be less stormy if we don't do the whole hog at this stage. This is my personal opinion based on my years of practice and seeing what happens to these patients actually on the ground level. I'm not talking about conferences and I'm not talking about x-rays. You can get a beautiful x-ray by fusing this patient, but whether clinically you're going to get a good result and whether that result is going to last for many years, that I don't know. I feel that if you do a root decompression, it will last for a few years. She will be okay for 4, 5, 6, 7, 8 years. Her activity levels will go down and she will be able to pull through, is what I feel.
See, there are a couple of things over here. One is that, as Sameer said, the radiological picture, if you see the AP and lateral views both, in the AP view, there's significant coronal sort of malalignment. In the lateral view, there's significant sagittal malalignment in the sense that there's significant kyphos in the lumbar spine. Now, in this scenario, if you also see the axial views, there's a significant amount of facetal tropism which is associated at multiple levels. So you see the facets are not entirely. So for us to decompress the roots, probably we might have to go in and get the whole of the facet out. Otherwise, it would be an incomplete job, especially on the concave side of the deformity. So in that case, obviously we will preoperatively counsel the patient. There is a possibility of this patient worsening with only a decompression procedure, especially when the coronal and the sagittal parameters are not in our favor.
I think just to chip in what has been discussed so far, that the options of management in this patient are: number one, only decompression of L4-5-3-4 area, number one option. Number two option is decompress the two levels and do a short segment fusion. And the third option is decompress those areas and go all the way long to do a deformity correction apart from decompression also. With all these three options in mind, may I just catch up on Dr. Gabriel? Dr. Gabriel, now there is a lot being spoken about deformity correction in these patients. But on the other hand, there are many number of papers talking about risk mitigation, medical optimization, age being an independent risk factor to mortality and complications in adult deformity. Where is the fine balance? How do we say that we can balance and have a risk-benefit analysis and say that this procedure is best for this particular patient?
I think thanks again for inviting me to join these discussions. And then I think in this particular case, I will probably follow Dr. Samir's advice. And because the patient is being presented to us in regards to the leg pain for the five months, and she has this deformity for a long time, and that is the area that has not been troubling her. And also, if you look at, although there's a lot of significant deformity, if you look at the MRI just now, you look at the sagittal skull film of the MRI, the deformity is actually quite flexible and quite correctable. And also, if you look at the all the kyphosis is actually quite neutral. If you look at the skull MRI, and also if you look at the coronal view on the if you look at just the top view on that, you see the kyphosis is quite flat. It's quite all right. And then if you look at just now when I saw there's a coronal view as well. And then in the coronal view, your coronal, now if you look at that just now, the sagittal MRI is quite well. And I understand there's a coronal view on the MRI as well. And then you can actually see that the deformity is not as bad as we want one thing. And certainly it's flexible. So once we'll wonder whether the deformity is due to the acute decompensation of the leg pain of the disc that is causing the problem. Especially the symptom is that if she has no pain or management quite well for the last 10 years, and all of a sudden they have five months of leg pain, and then the nerve block actually did confirm that L4-5 is a problem. Now, so I would probably approach like Samir, and then maybe offer the decompression as L4-5. And if you look at the plain X-ray at L4-5, there is no deformity as such. Yeah. So looking at this particular area, you do a tubular decompression or maybe an endoscopic decompression, you hardly destroy anything. Even though if you destroy something, based on the literature, on the Japanese literature, in deformities, scoliosis, the recurrence rate for decompression is between about 25 to 30% plus or minus. So if you, after counseling the patient, and especially if the patient is 17 years old, have no previous problem, or if you have multiple comorbidity, and I would probably do a decompression first and see how it goes from there, just particularly decompressing the lateral border of the traversing nerve root at L5, that particular little kink that is at the junction between the lamina and the upper L5. And then that would probably may relieve some of this compression in there. Yes, there's a facet hypertrophy over there, but you look at the angle of the thing is probably still greater than, not as deep as 50 degree or 60 degree. You can take away half of it, the facet is still relatively stable. So as you know, when the facet angle is more than 50 degree, then those are the area that you might cause exogenic instability, and this particular facet is not too bad. Once you decompress a little bit further out, you might be able to get that nerve root out quite easily. Now, in regards to the L3-4, I'm thinking about whether should I do it at L3-4. If I'm going to do a tubular decompression using a 50 millimeter tubes, maybe I would do two of them together. If I'm using endoscopic, then maybe I would just go for L4-5, just the interlaminar endoscopic decompression at that particular junction. So that is my current thinking about that. And then in the future, if I have to do the deformities, then probably something like T11 to iliac, and then with some interbodies, and then to get the lordosis back, and that is probably what I would have done. Thank you very much.
Thank you, Dr. Gabriel. I think that
Kind of
mentions very
endoscopic
much how
procedure.
to approach these patients. Dr. Mihir, what are your indications? Like we all are worried about fusion. Dr. Samir mentioned that doing the whole hog can have problems. Dr. Uday just mentioned that it can be a failing fight already if you enter into the fusion zone. We already have surgeons thinking about not fusing this spine. So what are the indications of fusion in patients with degens scoliosis? What are the times when you surely have to fuse them and don't think about the problems that may come up later? Dr. Mihir Bapat.
No, I think first let us try to analyze what Samir has said. Now, we are very sure that our root block has worked at L4-5. But the thing is, have we blocked the L4 root or the L5 root? It
L5.
means two separate meaning. Now, if you look at the coronal image on the MRI, there is a significant lateral listhesis at L3-4. Now, when you go closer to the apex of the deformity, that means apex of the deformity is L1, 2, L2, 3. When you go closer to the apex of the deformity and you have a lateral listhesis like this, and when you have a left-sided stenosis on your MRI, that means that the whole spine is rotated towards the left. The disc, the facets are crowding together in that lateral recess. So there is definitely a double crush of the L4, not only at L3-4, but also at L4-5. So I would be a little worried doing only L4-5 in this case, because L3-4 becomes significant in the event of a lateral listhesis. Now that comes to your second question. Because you are going closer and closer to the apex of the deformity, do you want to fuse this or you don't want to fuse this? Now, this lady has been living with this deformity. Like you mentioned, she's been a fit lady doing everything possible that she wanted to do. So apparently there is no mechanical problem relating to the deformity in her case. And that is why addressing the deformity in this particular case is not the aim. But you have to think of L3-4 also when you are decompressing, because that will be the cause of her symptoms. And doing L4-5 may not help her getting rid of her leg pain.
Anybody for fusion? Mir sir or Dr. Srivastava?
At this point, no fusion. This looks like
may I just check? Sorry, the patient is clinically having L5 pain, right?
Yes, clinically having L5 pain.
There's no medial leg pain, no back of leg pain, right?
No front of thigh pain, no L2, L3 dermatome, no L4 dermatome even. There is no anterior shin pain. Though on the axial images, if you see on the right side at L2, 3, the foramen is very, very tight with facet subluxation also.
Sure.
But there is no right side pain and left no thigh pain. It's purely L5 dermatomal area.
Can I
Dr. Gautam,
add something?
Dr. Gautam, since you are here, maybe have your opinion on this. Dr. Gautam, unmute please. Dr. Gautam, unmute please.
Saying that since I am calling from Devlali, not from Bombay, I'm hoping that this session will be people casting their opinions and saying why, rather than we conducting a studying session. Why are you doing? What are the indications of fusion? What are the indications for decompression? No, it's a clinical meeting. Let Mir say why, if he wants to do fusion, why, and let's move forward. Let everybody cast their opinions, what they want to do. I agree with whatever has been said by Samir. I would like to do a decompression alone, because anyway, I would actually not like to touch this patient. I would like to send it to Samir at Hinduja.
Perfect. So I think that sets the ball rolling. The fight is on. Samir and Gautam on one side, Mihir and Arvind and Vikas Gupta on the other side. We have guys who will do next block retractor and decompression. Yes, Dr. Gautam.
Whatever you do, she will make your life miserable. She will be your patient for life. She'll go and tell 20 other patients, don't go to Gautam Zaveri or to Samir Dalvi. That is what is going to happen with this patient.
No, even worse is don't do spine surgery.
Don't do spine surgery. So this is what is going to happen with this kind of patient. So if you can still give her one more epidural injection, still conserve her, let her come to you begging for surgery. Let her wait for another 3 to 6 months. If she has no neurologic deficit, give her another injection. Let her cry for surgery. Before she will at least accept that, and when you tell her surgery, as Gabriel mentioned, you need to tell her very clearly that after decompression is not the end of the story, and you will get symptoms within a few years if you live longer. So this is going to be the story. She's going to make your life miserable.
I think that is perfect answer from there, and I think I'll hand over the proceedings to Dr. Sandeep Sonone. The ball is already set. The fight is on. Sandeep, over to you to convene the meeting from here on.
Thank you, Vishal. Thank you very much. So without wasting any more time, again we would like to welcome Dr. Gabriel from Singapore for joining us over here, and we'll start with his talk on this particular topic and the role of minimally invasive fixation in this degenerative conditions. So can we start with your talk, Dr. Gabriel? Yeah, you need to unmute yourself. Dr. Gabriel, unmute yourself.
Right. Thank you very much for your kind invite. Once again, I want to thank Bombay Spine Society and also the President for the kind invite, and particularly Sandeep and also Vishal for organizing this and the advice that they have been given me. I've seen a lot of old friends and then new friends, and then they're basically in the meetings, and I just want to say hello to all of you guys. It is a privilege for me to join the meeting, and then I remember almost 15 years ago when Dr. Bojiraj was hosting the meeting, I was one of the guests inside the meeting when physically meeting all of you, and I have a wonderful time. And again, it is my honor to be able to be part of your meeting. The topic that have been selected and discussed and is the circumferential MIS adult lumbar deformity corrections. So as you all know, MIS surgery have the advantage of doing certain things, right? It reduce the blood loss, it reduce the post-op pain, shorter recovery time, maybe better long-term disability effects. Now, the literature have shown, for example, MIS fixation fracture. In this meta-analysis, over 600 patients, they have proven MIS spinal fixation fracture would have a better, shorter operating time, shorter hospital stay, reduced blood loss, and less infection outcome. Similarly, in this patient, like a 79 years old with spinal mats, and then there are multiple mats and multiple MIS surgery have its roles as well to reduce and decompress the patient. Again, it's proven in meta-analysis, they demonstrated its effectiveness and usefulness. Perhaps majority of the MIS evidence really come from MIS T-leaf versus open T-leaf. It has been well proven that there is less pain, faster recovery time, early return to jobs, and then this allows you to do this type of operation, which many of you are expert in doing so. But in the literature, it also talks about T-leaves. If you do an MIS compared to open, the MIS T-leaf tends to, at 2 years, save more money compared to the open T-leaf procedure in terms of loss of work, rehabilitation, and early faster recovery patients. The current recommendation for fusion for deformity in lumbar, perhaps you need to include probably the end vertebrae on top and then the end vertebrae at the bottom, or the stable vertebrae at the bottom. So if you do things like that, you most likely end up fusing the L5S1. If you need to fuse the L5S1, you need some form of ilium fixation. That would be recommended. And of course, there's a lot of sagittal goals that you want to do. C7 SVA plumb line, that's going to be one. Nowadays, most of us will talk about age-adjusted C7 plumb line outcome, and also PILL mismatch, which has to be age-adjusted. And the majority of all the current literature, I think one of the things that is particularly important is to restore the lumbar lordosis at L4 to S1 as much as you can. And then those are the key things of doing the in here. This is one of the case, 74 years old lady who have a deformity like that, and then we do something like that, which is using an open technique. She's 8 years out after surgery. She's still doing well. So if you respect some of the principle, I think most of them, they are okay. And this is what it looks like. The question is, how do we translate this understanding into the MIS deformity surgery? We know in children, we can do thoracoscopic fusion quite easily and have a good outcome. The reason being that it is because of the fact that you have good, reliable interbody fusion mechanisms. And similarly, we can do MIS posterior non-fusion technology. For example, in the magic growing rod system, we can do something like that, which is quite reasonable for MIS and with good outcome using this group of patients. Now, in the literature, Sawahi have attempted to correct the AIS using all posterior MIS techniques, using a tubular facet fusion method. It has been done, and then it has been reported in this paper is a good result. But the problem with this translating to adult deformity is that facet technique is good enough for us to do the fusion over that area. So in my mind, the current problem for MIS surgery in adult is that we have no good MIS facet or posterolateral fusion. In addition to this, as you all know, in the open lumbar deformity surgery, complication rate can range from 60 to 80% depending on which paper that you read, and therefore is going to be difficult. So how do we do this? Now, what is it reported in the literature? Michael Wang and Praveen Mamani, which many of you know as a friend of you in the society, 10 years ago reported a deformity correction like this. So majority of them is really a lumbar curve, and then it's not really addressing the L5 nerve root pain or an S1 pain. It's really deformity corrections like this. And notice that in their series, the correction ability is about 30-degree Cobb angle, and then most of the curves, they are corrected something like that. Subsequently, a larger multi-center study demonstrating that the overall complication using the MIS technology is about 33% plus or minus of weakness, but permanent damage may be about 12%. And this, they concluded the fact that, okay, these are actually relatively comparable to adult deformity surgery. But mind you, in their paper, the average scoliosis is only 25-degree plus or minus. So is this really true? So looking through the literature, most of them are basically fusing a lumbar 5C curve in AIS, that type of thing. And then if they are not really dealing with deformity with an L5 radiculopathy, L4 radiculopathy, or S1 radiculopathy type of situation. For those who are dealing with it, then they would tend to fuse the L5 S1 using various different techniques, but there's no ilium fixation. And when you do that, you know from the literature, pseudoarthrosis in the L5 S1 is going to be very high, and sacral fracture is going to be a problem, loss of sagittal correction is going to be a problem as well. So how do we do MIS deformity? Praveen in UCSF have give us a classification to look into this, right? So looking at SVA less than 6 centimeter, PT 25, LL, lumbar lordosis and pelvic instant mismatch for 10-degree or curve angle less than 20-degree, they call it class 1. And in this particular situation, maybe just decompression is sufficient. And then whereas if it is bigger, that with this type of deformity, PILL mismatch more than 30-degree, or there's a thoracolumbar kyphosis, then maybe segmental fusion within the body fusion is important. And in addition, if the curve is larger than that, then the concept of using a PSO and then the anterior column reconstruction, using various lateral body into body fusion cages and hybrid approach, circumferential approach of MIS surgery is recommended. But for those deformity who is more than 5 level, involving L5S1, or maybe involving 10 levels of ankylosing spine, the group has actually still recommend open surgery instead of doing MIS deformity corrections. And if you are going to do MIS deformity, what are you expecting to get for each level? If you put a interbody cage into the lumbar spine, you will expect about 25-degree correction. If you put it in the body cage in the lumbar spine, put an MIS screw at the back, you get about 35-degree correction. If you put it in the body cage into the lumbar spine and cut open at the back and do the correction at the back with open technique, you might get a higher correction power. Looking at this particular group, basically this is the ISSG group, which you guys are all familiar with. But of course, if you use a MIS techniques with open surgery, MIS in front, but open surgery at the back, this is called hybrid approach, or circumferential MIS, which is MIS on the lateral approach and MIS at the back of the spine, then MIS hybrid approach will have a higher complication rate, which is expected, even though that you have a bigger corrective powers. So in my current series, we have about 30 patients plus or minus, 20 is adult deformity. On average, COP is about 40 degrees plus or minus. So far, 2 years outcome to 5 years outcome, they are acceptable. But unfortunately, there's 3 rod breakage. And then at the L5S1 level at 2 years follow-up, I will explain to you why subsequently. My current strategy for MIS fixation is circumferential MIS fixation is really relying on 3 principles. The first one is interbody fusion techniques. And I needed to have a good biologic, and I need to have stable fixation into the ilia. So in the interbody, you can choose anterior, transperitoneal, axial lift, and lateral is going to be X lift, D lift, which is transverse approach, or O lift, which is anterior psoas approach. And of course, we're developing our own concept, which is called Ox lift, which is combining X lift and O lift together. And of course, the workhorse, which is MIS T lift posteriorly. And BMP is going to be one of the things that we use, or maybe biologics, DBM, and things like that. And the fixation techniques that have been well described in various different aspects. The thing that is marked on yellow is the techniques that I use most of the time, and then in order to do this type of deformity correction. So let's run through 1 or 2 quickly. Axial lift that have been described in probably 5-6 years ago, and gain good result, and then basically do something like that. Yeah, but now there's none of us actually do this type of thing anymore, despite the initial good result, because as you follow up after about 2 years, you realize that there may be migration of the screw between the L5S1, especially 2 level, breakage as well, and loosening. And so many more of us are moving away from these techniques. And also the fact that you're operating next to the rectum, and it's not particularly comforting. In the Taiwan groups, they have demonstrated, okay, I have deformity, I can do multiple MIS T lifts. Yes, it can actually give rise to good result of corrections. But all of us know when you do the MIS T lift, 1 level, maybe if you're fast, maybe take about two hours plus or minus. By the time you do 4 or 5 levels, you are alone there doing MIS T lift. It's going to take a long time, and it's going to be very tiring. And as a result of that, the lateral approaches have been developed, which is really either through the psoas muscle, insert into the cage, or anterior to the psoas muscle, inserting the cage. This is currently how I do the X lift and the D lift. I mark the spine after you corrected the deformity, and then dissecting the retroperitoneal away from the area, and then you use II to mark the location, and you use neuromonitoring to check on the dilator, and putting the scope in through the psoas muscles into the disc space and where we are. The advantage of these lateral interbody cages is instead compared to the T-leaf is the fact that the cages are extending from rim to rim. And when it extended from rim to rim, it has a tremendous corrective power, is able to withhold subsidence, and is able to also distract the spine, which is shown in the classical Pimenta study that after you insert the cage, you're able to open up 33% of the lateral recess without decompression posteriorly for those particular lateral recess decompressions. So after you have done that, then you open up the cage, and the way that we look at the cage is being inserted, you just basically drop the cage into the spine after you rotate the table, then that segment to correct the deformity. So there's no worries about how much of deformity correction you need to achieve. Basically, it all corrected segment by segment by rotating the table. You just drop the cage inside, so which is quite good in form of deformity correction in this technique. Currently, I still rely on biologics, and that's why you saw I wrap the formal graft with a strip of BMP. For those who want to save some money, you can actually use Osteocell Plus, and which is MSC cell, and they tend to give good results as well based on URI-based study. The problem with the X-leaf and D-leaf is that there's thigh numbness, which can occur up to about 30 to 40% of them, particularly is when you do it at L4-5. So the way to avoid the L45, first of all, you need to know your lumbosacral plexus. The insertion point for L45 for this type of lateral approach is in the center, not the posterior 1/3. And try not to break the table too much. If you do that, it stresses the psoas muscle, and as a result, then they might have more numbness in the spine. Other tips that I've learned over the years is, for example, from this paper, sometimes if you do a concave side, especially L45, you will expect more complication, or just be aware there might be more complication. So we'll be careful with it. Maybe the L45 is too deep in this concave side. That's one of the reasons to it. And in the Japanese group study, they actually demonstrated if the curved segment is more than 15 segmental Cobb angle, and particularly in female, you see the dot over the arrow, that is where the segmental vessel is going to be. So sometimes, if you open up the retractor too much, you might cause an iatrogenic bleeding into the segmental vessel, which you're not aware of as well. So these are some of the things that you want to watch out for. Many of you already know the Mickey Mouse sign, or the high rising psoas sign, which is if the psoas muscle is anterior to the neuroforamen. And that means, and now if you want to put a transpsoas approach, a cage through the psoas muscle into the body area. In this particular situation, the cage will definitely go through the lumbosacral plexus, and this will be a contraindication to the techniques as well, which is a high rising psoas sign. There's an advantage of using X-leaf and D-leaf, and then because of the direct dropping of the cage there, you can actually use a very hyperlordotic cage. And then with a bit of a relief of the anterior longitudinal ligament, you can easily put in a 20-degree cage there, or maybe even 30-degree cage there, particularly good for segmental significant kyphosis segment, that type of deformity. You can really correct the spine quite nicely in there. For those who doesn't want to go through the psoas, there's the anterior psoas approach, and this is how I do the approach. Notice that we're now standing in front of the patient, which many of you know, and then by dissecting the spine, going through, which is quite easy to do actually in terms of the approach. You can go through the plane between the retroperitoneum, anterior to the psoas, and then you can insert the instrument there. The only thing with this particular approach is that because it is obliquely inserted into the instrument like that, sometimes we're worried about damaging the contralateral area of the spine, contralateral nerve root, and therefore we need to be aware of that. And when we be aware of that, sometimes we become a bit scared, and therefore we don't put as long as a cage as we want to, from rim to rim, in order to get the maximum benefit of the lateral interbody cage to do this type of surgery. Yes, we know we need to do the orthogonal maneuver in order to avoid this complication, but sometimes this thing can still happen in this particular area. Now, in the event, many of us worried about this approach damaging the vein, and then in the actual study, many of these vein damage is not quite high. But the only problem is that when it happens, if you operated through a small little hole, are you ready? Do you have in your hospital? Do you have the mechanism to repair that vessel? Is particularly important. So I've torn those vessels before, and luckily every time before I do this type of surgery, I will ask my vascular surgeon to stand by, and I have my laparotomy step to stand by. And then the minute, if the vein actually happens, you don't know where is it bleeding, the best thing is to put a long finger and just pack it. And once you pack it, meanwhile, you just open up, use a laparotomy to open up the wound more, and then call your vascular friends to come and help you to repair of the place. Now, doing in high rising psoas patients in the OLIF, some patients might also complain of anterior thigh numbness initially because of the stretching of the nerve. And as you know, for this OLIF type of situation, you have to do it on the left side, or recommended to do it on the left side, where there's a vascular corridor at least about 1 centimeter or 1.5 centimeter, so that you can actually do the surgery in that area. I've tried to do it on the right side before. We can dissect the vena cava away from the disc space. It can be done, but after I've tried it once, I don't want to do it again. So that's basically where we are. Now, when we compare the OLIF and the X-leaf, and then some of the OLIF, they tend to increase the foraminal height a little bit more. And then whereas in the X-leaf and the D-leaf, they might get a better number of lordosis. And then maybe this may be due to the positioning of the cage, that the control of the positioning of the cage, which Neil Anand have talked about, which again is a good friend to your society, I understand. So looking at some of the meta-analysis, you can actually look at 6,000 patients in 39 study, and then the transverse patient is definitely have a higher sensory deficit, high hip flexor weakness, and permanent neurological deficit is about 2%, 2 or 3% versus 1% to anti-psoas, and infection rate is maybe a bit higher. But in the anterior psoas or the pre-psoas approach, the sympathetic nervous system and vascular injury is definitely a little bit higher compared to those. Subsequently, the rest of the things, they are similar comparing to two approach. Another things about the MIS deformity or deformity on host is, as we mentioned earlier on, 2/3 of the lumbar lordosis occurs between L4-5 and L5-S1. So all the maximum effort, irrespective of what are the papers you see, oh, this formula, that formula. And then the key thing that I found that how my practice is to restore as much lordosis as you can get between the L4-5, L5-S1, irrespective which Russell-Uni curve you talk about and which type of calculation, the French approach, the American approach, and then these are some of the things, our sitting approach, these are some of the things. The best is to restore your lordosis between L4-5 and L5-S1. So with that in mind, then of course we need to do some sort of anterior interbody lumbar fusion. So this is how we perform the anterior interbody fusion, which is basically like an olive and then basically dissecting about that, which is nothing unusual compared to that once you get a hang to it. The only thing I want to highlight to you is that when you put in the first retractor in this area on the iliac vein, sometimes what I found is that when I put the retractor, the blue retractor on top, and then with the black arrows putting in this common iliac vein, I occlude the venous return on that vein. And as a result, when I put in the retractor at the apex, I can't find the vein border. And because it's already collapsed, and the vein border looks similar, like and connecting to the anterior portion of the disc space. So if you're not aware of that, sometimes when you think that is a disc space, you cut right into it. Actually, there's a collapsed vein there, and that's created a blood vessels. So every now and then, release that blue retractor on top, find the vein border, then you apply the apical retractor, and that helps you to save a lot of, save me from going through some of my painful experience in that particular aspect of it. So recently, we have been developing this technique, basically merging the X-leaf and the O-leaf together. And then basically we will, and then of course have the advantage between the two aspects. And then basically what you do is a direct approach, standing behind the patient, use a finger dissection to retract the psoas muscle back. And then from that, the slightly oblique inserting the guide wire under direct vision into the disc space, and from then using the posterior blade of the retractor, any form of retractor, to track the psoas muscles behind and to use the method. So with that, we have been able to do many of these decompression and reduce some of the anterior thigh numbness, reduce particularly the L4-5, and then reduce some of the sensory and sympathetic nervous system complication that has been described. But yet, because it is direct approach, it is good for more higher deformity correction, for example, more than 30 degrees, that you don't need to worry about orthogonal maneuver, whether the cage is going into the contralateral nerve root and things like that. So this is particularly have been useful in my practice. So the other things that we have been learning is that good biologics is important. As you all know, BMP is expensive, and then using many of them. So we have been trying to use what we call ultra low dose BMP, which is 0.7 milligram per facet in posterior fixation. In the interbody fusion, we have been using 1.4 milligram of BMP, and we are able to achieve majority of the fusion, and about 90% using a CT analysis. However, as we mentioned, the L5S1, they tend to give a little bit of a problem. And then in that particular situation, nowadays we increase the dosage to about 2 milligram in the L5S1 region, and then to reduce the rod breakage. And especially if your patients are on chronic steroid, those are the people that you might actually need to actually either increase the dose or do a really thorough discectomy, or may even add one more rod in order to stabilize the area instead of doing just a L5S1 fixation in there. A good, reliable posterior fixation is important. And then in order to do the ilium, nowadays we do have the iliac screw and the S2A iliac screw. And the problem with the iliac screw is that it's very prominent. Even though you recess the posterior superior iliac spine, it is still prominent because the rod is sticking out, and you might need to use a side connector in order to link up the proximal construct to the iliac screws. So that's why the Calcubascia developed the S2A iliac screw following from Ponseti, which actually described the screw in children. And when they do this, basically it is inserted a screw between the S1 S2 foramen through the SI joint into the ilium, and that's basically like what's shown in the diagram. We did a review on the study and then demonstrating and confirm that the S2A iliac screw had less complication compared to the iliac screw, traditional iliac screw, in terms of painful prominence, wound complications, screw loosening, and implant failure and revision. The only caveat to this particular study that we have is that there is a learning. We realize in the majority of the poor iliac screw data come from the early phase of the study, where the surgeons are doing the learning curve. Once they realize, oh, I need to recess the iliac crest a little bit to countersink the screw a bit better, and then to sit a little bit better, then those complication rate reduce a little bit. The S2A iliac screw is not without problem. So for example, by the time you put in a screw, 60% of this type of screw will go through the SI joint, the articular surface of the SI joint. And when that happens, the long-term SI joint arthritis may occur. And also, it has been reported by the Nightingale Hospital in Egypt that in the severe osteoporotic patient, the S2A iliac screw may fail faster compared to the iliac screw because of the severe osteoporosis occurs in the sacrum, leading to lack of proximal hold of the screw. As you know, the strength of the screw is between the outer and the inner table at the ilium. That's where you actually hold it, which is synonymous to the pedicle screw, whereas the strength is at the isthmus of the pedicle. So we developed the subcrestal iliac screw. Many of you might have seen this already. The entry point of the screw is that we enter into the inner table of the iliac crest. And this is basically located at the area just like the S2A iliac screw between the S1 and S2 foramen, but above the SI joint. Okay, so just immediately above the SI joint, and then at least about 1 and 1.5 cm below the iliac crest on the inner table, you can insert the screws like that inside that. It has the advantage of the S2A iliac screw and the advantage of the iliac screw, and less of this complication related to the two screws. This is what it looks like in here. So in this particular area, after you've dissected the deformity, and then you can see that we don't need to dissect as much as the traditional iliac screw to expose the whole ilium. You just expose a little bit on the medial surface. And then once you identify the area between the S1 and S2 foramen, and then just above the SI joint, and then you just make a burr hole in there, and then put your finger on the greater trochanter like the traditional iliac screw, and then basically by feel between the outer and the inner table and crunching the cancellous bone in the center, you can actually get inside the screw using a freehand technique quite fast. And then after you have done that, use a feeler to deepen the hole, and then you use a straight awl to continue to widen that. And around 50-60 centimeter often is a bit tight over there, and then you need to knock it into it. And then once you knock into it, then you can actually get quite a good size bone in there. Use a normal guide wire as a long feeler, and then to check it like a normal pedicle screws, and then you measure the length. Nowadays, the traditional screw that we use actually is about size 9 diameters, and then length is about 90 millimeter plus or minus, which is quite a strong screws in there. The other things about the tricks about putting in the screw is that once you try to after you zero dilate the area, and when you're putting in the screw, you should continue doing it. The minute you start to stop, the bone does tend to catch into the screw. By the way, I under tap the screw a little bit to increase the stability and the grip. And then the minute you start, don't stop. Once you stop, you might get jammed inside, so that might be a bit difficult. Most of these screws are quite okay, but unfortunately, 2 weeks ago, I did the same screw, and then I have a first case of fat embolism. Then the patient have a BP drop, so that might be a potential problem. So do please be aware of this potential problem. So in this situation, another trick is that by using a long sleeve, and then like the MIS sleeve, you use this connected to the ILEX screw, you use this as a reduction device. Then now you can connect the proximal construct to the distal construct without using a side connector. And that will much reduce the cost of your surgery as well, and to allow you to do it quite easily. And again, after the surgery, this is still the ILEX screw, subcrestal is still ILEX screw, it doesn't go through the SI joint. We publish the techniques also in using an MIS technique as well, and that is for your pursue. And then the only thing is that you have to get the teardrop. So how do you get the teardrop? Many of you know is by rotating the C-arm 45 degree like that, and then tilt the C-arm 45 degree, then you will get the teardrop at the ilium. And that is like a big pedicle for you to put in your screw. It has been a while when I first developed the techniques, and then I realized, oh, I'm trying to get the wire at the middle wall of the teardrop and then punch it through inside. It is very difficult. So after a while, I realized the best way to get the screw inside the teardrop is to don't use the II to guide it first. Once you use the II to guide between the S1 and S2 foramen to get that level. Once you get the level, use a finger dissection into the sacrum, walk yourself through the SI joint onto the middle wall of the iliac crest. Once you feel that iliac crest, then you put your screw straight, follow the fingertip, puncture through the middle wall of the ilium. Then you use the teardrop to check. Once you're in the teardrop, then you will be automatically in the teardrop. If you try to use the wire on the outer surface and use the teardrop to guide you through, inevitably you can't get inside. You have to puncture through the middle wall first and to get the right trajectory. So this is basically what we have learned through this. So throughout my journey, when we first started the deformity correction, this is what we do, and then we put the patient on the side, and then X-sleeve on the side, and we use thoracoscopic, and then at the upper T11, L1, T10, T11 region, and then after that you need to put in the chest tube, and then the posterior MIS fixation, and use some MIS T-leaf, and then to put in the rod, and then slide through, and this is what we got initially, and what we can get in here. It's a start, and then not the best, but that's how this is the first case that I've done. Subsequently, we move on to develop, okay, I don't actually need to do thoracoscopic. I can just use a mini open using those X-leaf retractor, D-leaf retractor, or O-leaf retractor, and then you can easily see this space and then put in this cage directly. So it's a direct transferal approach. And this is what we got, and then in there, and then you're able to make some sort of correction in there. As we get a little bit more experience, then we started to think about, oh, actually, we need to incorporate all the deformity principle in the spine. So by doing anterior AL release, we get a bit more lordosis in the kyphoscoliosis spine. And then by also doing a differential rod contouring, as well as reducing the deformity by pushing the rotation differential rod contouring, we're able to derotate the spine a little bit better, and then getting the corrections a little bit better. As we get a bit better, we're now able to plan the incision a little bit more and try to reduce some of the screw. Instead of every single level, we need to put screws at the back, which makes the wound looks pretty bad. So in this almost 80 years old lady, this is the type of deformity now we can get and correct, and that is basically like that. And of course, the patient has some neurological deficits. If not, we won't offer the patient surgery to start with in the beginning. And finally, we are able to attempt some of the really bad deformity like this, and then using MIS approach, and then from then able to do some of the corrections in this type of patients. So in summary, to perform the MIS deformity, one will need to know a combination of techniques, good interbody techniques, good biologics understanding, and good posterior fixation techniques. Some of the limitation perhaps may be whenever there's no good interbody fusion, for example, like ankylosing spine or extend multiple surgery, patient with colostomy, or very severe spondylolisthesis. Deformity that's really bad, like 60-degree or more, and then or you realize the patient have already maxed out the reciprocal corrections of the thoracic spine area, that you have to fuse all the way up to T2, T4 area. That type of patient would not be a good MIS fixation techniques as well. And finally, the costing is also important. So with that, I would like to thank you all for your kind invite and for me to share with you what we have learned from the MIS circumferential deformity. We hope to invite you to come to NUH again to visit us via various different society perhaps, or even come to join our fellowship. And recently, I understand that Dr. Vishal has been arranging an ASSI fellow to come to visit us, but because of the COVID-19, it has been put on hold. And every year in January, Singapore will have Singapore Spine Society annual meetings. We hope to see you guys online as well and to join us in this platform or present a paper for us so that we can learn what you guys are doing in your prestigious society. Thank you very much for your time. Thank you.
Thank you, Dr. Gabriel, and it was indeed a great talk. Now we would invite questions. And the first, Gautam, you can go on and ask the question, Dr. Gabriel.
Yeah, Gabriel, congratulations on a fantastic talk and fantastic work that you are doing. I had two questions, in fact, one technical one and one clinical one. The technical is that how do you maximize the lordosis of the lumbar spine when you're doing a transforaminal lumbar interbody fusion in these adult scoliosis patients?
So to maximize the lumbar lordosis in these MIS deformities, then it's really depending on how much lordosis that I need to get from that segment. So I know at L45 I need to get at least as much as I can. If I can squeeze in a 12-degree or even 20-degree cage, and then I would do that. So, and then also depending on how flexible it is. Now, if you look at the spine, if the spine have facet fluid sign, okay, so I know I can put in the cage quite nicely, it will correct itself. And then if I see that a disc have vacuum sign, and then I know, although the disc is collapsed, I can correct it because they are mobile. So these are some of the signs that you know that you can actually get a good lordosis using the lateral interbody cage techniques. Now, for those who are really have to get a good lordosis, and then I have to release the anterior longitudinal ligament and then put in a 20-degree cage with a screw to stabilize it. And for those who are really have to get more lordosis, then I need to go to the back of the facet to do a facet release like a pointed osteotomy at the back to get that segmental lordosis. In a TLIF method, we actually develop an internal facet release type of mechanisms. So instead of doing the over-the-top decompression, not only after the over-the-top decompression, we further decompress all the way to the undersurface of that SAP. And then by taking out the undersurface of the SAP, we're able to release the contralateral facet a little bit. And then that has been developing at the moment, but we have no results yet.
Gabriel, you spoke about maximizing the lumbar lordosis. There's a lot of talk about age-related correction. That's correction of the mismatch between the PI and the lumbar lordosis. So can you just go and go through a bit of pre-operative planning, especially in MIS cases, as to what is the amount of lordosis that you actually want to achieve on table, considering the age of the patient?
Yeah, so I think majority of the age of the lordosis is that if people is between 65 or 70, then you probably can follow most of the guidelines as per what we want. Once the patient has become 70, 75, then the key thing is really undercorrect. And then instead of following the SVA, which is about 5 centimeter, you go to 7 or 8 centimeter. The PILL mismatch, instead of following about 10 degrees, go up to 15 to even 20 degree plus or minus. And this has been described in a classical paper by Renaud Lavache, and then which is Virginia Lavache family, and then using about 700 patients. So they have listed all the criteria, what you want to correct. But in short, is that people who are elderly and the 65, 70 and above, I would not try to correct it as what the spine needs to be. Has been described by Schwab last time, and then we'll try to under correct them. For example, I would accept up to about 8-10 centimeter SVA to a certain extent if the patient is very old, and these are some of the things that I would aim for. And the key thing to get the lordosis is really the L4-5 and L5S1 is the one that you want to get. There's a lot of talks of how do you plan your lordosis, which one to do, but at the end of the day, I find the best thing is to get it at L4-5, L5S1 because of the sitting data. If you sit the patient up, you realize that L3-4, L2-3, L1-2, they're all kyphosing. Because of this phenomena, you may have early PJK as well if you overcorrected the lordosis. But having said that, if it's a type 4 Riccioli curve, then you need those lordosis in those particular areas. So in short of planning the lordosis, the first thing first is that overall the global lordosis is what? And then the second thing to understand is try to restore as much as we can as L4-5, L5S1. Finally, to see whether we need to have an upper lordosis correction in that case by looking at what type of curve is this patient is going to be. If it's a Riccioli type 4 curve, which means you need to have lordotic L1, L2, L2, L3 segment, then in those situations, you need to have a hyperlordotic cage in those areas as well, as opposed to most of the curves are type 2 curves, which basically just correct the L4-5, L5S1 should be sufficient.
Gabriel, just to finish my second part of my question, which is the clinical part, when we talk about surgery for degeneratives or adult scolies, there are three issues which we are concerned about. One is intraop or immediate postoperative complications. The second is delayed complications such as proximal junctional failure or distal junctional failures. And the third is an outcome problem, and that is that in spite of everything going well, the patient has done well, there are no complications immediate or late at that point, but this patient still continues to have significant back pain and is unhappy with the outcome of surgery. How has minimal invasive lumbar interbody fusion affected these three issues? Has it changed the outcome in terms of the overall outcome rate? Has it changed the incidence of early complications and late complications?
I think in terms of, thank you very much for very, very good questions. And then I do open surgery as well. And then I started with open deformity correction. I still do open deformity corrections. And then, but in selected cases, we do MIS. That is one of our passions. And then, so in regards to the early comparison of the intraoperative complication, when you do many of you do the lateral approaches, and then you sleep in 6 cages in the lateral approach, or 3, 4, 5 cages in the lateral approach, and then through 2 small little holes, and then from the side of the body, and then correcting about 4, 5, 6 segments at the time of the surgery as a first stage surgery. The next day you see the patient is waving at you sitting up. You can even stand them to an erect X-ray. Those are really quite good. And then it is when you do the posterior MIS fixation, and then sometimes if you need to add decompression, then the blood loss will come back a little bit. Otherwise, they are really have faster, immediate in terms of pain-wise and movements-wise, would be quite good. But once you need to do a decompression, when you need to do another T-leaf at the back, then yes, the blood loss will come depending on how you control them. Now, in regards to the long-term outcome, or PJK, by respecting the proximal muscles envelopes and the distal muscle envelopes, they tend to have maybe a little bit less PJK, and then from that, which was actually described by the ISSG group data. Now, in addition to this, recently, what we have been doing is that to avoid the PJK, I tend to fuse all the way as much as I can. I don't go up all the way to T10 so much anymore. I start to stop at around just the end vertebrae or just at above the end vertebrae, which is different from what Suk data have been described. And then, but instead of doing that, I start to do vertebroplasty on top. So by doing that, and then you're able to stabilize the bone, probably again Kao-Kibash data, and then or an ISSG data, and then you do a proximal screw cement, and then the proximal level, one level cement, or sometimes if you think there's a curve is square bed, and then there are really kyphotic SVA 16, that type of thing, then you do a two-level cement. You're able to reduce some of the PJK function over there, and at the same time feels less, and yet maintain the mobility. I think the key thing is to maintain some of the flexibility that will help to reduce some of the rigid construct-induced complications. That is basically where we are facing off. In regards to the long-term outcome, once you fuse it, you think it fuses nicely, but the patient is still shouting at you, I have back pain. That one I will have to follow Professor Uniko Matsuyama's principle. Before you do the surgery, you teach the patient how to clean the buttocks, how to wear the socks, how to do the exercise. You get them understanding what is happening. If need be, you brace them and then let them feel, do they like that type of spine being so straight? And then if they don't, so maybe fusion correcting the deformity is not a cup of tea for the patient. Or certainly you need to warn the patient these are some of the things. Or by doing this type of exercise, you also will dial down the expectation. Some of the patients, you fuse them from T2 to iliac, they can't clean the buttocks. They can't sit on the floor. They don't like it. And then so they're not aware of it in the beginning, or I'm not aware of it in the beginning until you have such a case. So following the Japanese data, you teach them first, give them a robust regime, and then to train them, and then that helps to reduce some of the expectation mismatch problems. Thank you.
Thank you. Gabriel, just one question.
Yes, sir.
You spoke about fusion. So one of the concern in MIS surgery is the fusion mass that we routinely see in open surgeries, right? So in your series, do you have a sequence where you do routine post-operative CT scans? On the CT scans, when are you convinced that this particular segment or the zone is getting fused? And what is the incidence of radiological and clinical non-union?
Yeah, I think initially we do the CT scan, and then if we do the posterior open fixation, we still use BMP. So so in our situation, I think we only did it for the open at the initial stage. In the MIS stage, we didn't routinely do a CT scan afterwards. But what I start to notice is that the people who have rod breakage, which I mentioned earlier on, they have L5S1 pseudo. And but when I do the CT scan on those patients to discover the L5S1 pseudo, the majority of the higher level, they are already fused. You can see they're fused quite nicely. So I think I got the dosage of the biologics right for the upper level, but the L5S1, I still have not got it right yet. And one of the things that I've been trying to do is to skip the S1 screw. So maybe that is a mistake why they break. And not that I can't put in an S1 screw together with the iliac screw, it's just that I thought if I have a strong 9mm iliac screw, and then I have good L5 screw, I have good interbody fusion cage, why do I still need an S1 screw? That was the concept that I was thinking. And but with that, I have two to three rod breakage, and two of them are on. One is SLE patient who are on steroid. The other one is chronic asthma who is also on steroid. And then the third one is probably just my fault. And so with that in mind, now I'm using a 6mm diameter cobalt chrome rod, and increasing the dosage of L5S1. So I'm seeing whether this will break or not. If not, then I'll just go back to S1 screw, following up the open data. Then that will probably avoid all this complication.
Thank you, Gabriel. Dr. Srivastava wanted to ask a question. Last one.
So, Professor Gabriel, very good talk. I just have one question that irrespective whether you do open surgery or minimal invasive, osteoporosis remains the problem. So what is the incidence of end plate fracture or sinking of the cases in your series?
Yeah, thank you very much for very good questions. And then osteoporosis is really one of the biggest fear that we have. And then in this particular area, again, we are a little bit spoiled. I use BMP, so it helps a little bit for early fusion. And then for those cages which I'm trying to be very ambitious. May it be a lateral in-body cage when I put it in, and then I fracture the end plate, or maybe using a hyperlordotic cage in T-leaf, rotate the cage to get the lordosis, I fracture the end plate. What I try to do is to put in a rough screw at the back. So what it means by that is that by putting in the screw just at the end plate fracture, supporting the cage, it tends to help a lot. And also, if it's in the body, lateral in the body cage, remember we talk about is extending from rim to rim. A little bit of end plate fracture is still quite acceptable because the actual holding it is the rim and the rim. So I have the cage slightly a bit longer, and then at around the 3-4 and 4-5, I mean the aorta and iliac veins are not there. You can have it a little bit longer. It's okay. They are quite okay. And then at the back, just put in a rough screw to strap the cage. They are quite okay.
Thank you. Thank you, Dr. Gabriel. I think for want of time, I think we will wind up over here your session, and we would request you to continue to have your presence over here for the case discussion scenarios.
Thank
so
you
now
so much.
I would invite Amit to take over from here, and invite Agnivesh to load his presentation and start off with the cases.
Thank you, Sandeep. So we have these 6 to 8 cases lined up. We'll be discussing them one by one. And so we'll be starting with Agnivesh. He'll be presenting his first case. The way we will go will be he will be presenting his history and imagings. After that, we'll discuss what we think that should be done, and then Agnivesh will tell us that what he did, and then we can kind of again have a very short discussion. Agnivesh, please proceed.
Hi, good evening, everyone. Is my screen visible?
Yes, go on.
All right. So this is a 69-year-old female. She's a known case of diabetes and hypertension. She also has some minimal interstitial lung disease, has been on steroids. She presents with back pain and progressive weakness in the leg, and she's unable to stand and walk for the last 3 months. The powers in lower limb is 2/5 proximally, and distally it is around 3/5, except for EHL ADL, which is very minimal on left side. And she also has a history of hysterectomy done for some mild minimal malignancy, which was followed up after that and has been asymptomatic till now. So straight away I'll go to the image, and these are the MRI images of the patient.
So
all right, Uday sir?
Yeah, I guess
please.
move on with it.
So you're showing that we have a vertebral collapse at L1 and D11, and a disc coming up higher up at 5-6 level, correct?
Yes.
Are we missing something in the dorsal spine as well?
There are these marrow changes, if you can see them.
Okay.
There are these marrow changes, and the cord here is not visualized, but on sagittal there was no compression on the cord. There was no visible compression on the cord. These are the axials at 2 fracture level. This is the upper one, and this is the lower one.
So there is back pain and progressive weakness, correct?
Yes. There has been back pain, and there is progressive weakness in the legs.
So is Arvind around? Arvind Kulkarni?
Yeah, hi Amit.
Hi Arvind. So, Arvind, do you need any more investigation for this?
I will need axials in the neck, cervical spine.
Okay.
Okay. I don't have them right now, sir, but they were not.
Weakness, which cannot be explained by what is happening lower down. And what are the signs? LMN or UMN signs lower down the legs?
Sir, it's a weakness. It's the plantars are extensor, but there is no spasticity or this thing, very hyperreflexia.
I don't know.
And what about the upper limbs? What about the upper limbs?
Sir, upper limbs are normal, absolutely normal.
No. So my question, Agnivesh, is that forget the MRI. On a neurological examination, what is your neurological level? It's a lower motor neuron lesion, right? It is not an upper motor neuron lesion, and it is not cervical level.
No,
so
sir,
that cervical disc is a bit of a red herring, right? Because there is no signal change there either.
No, sir, no.
I think the most important issue here obviously is dynamic X-rays. We need to have a sitting lateral because probably one of these is collapsing and causing cord compression. There it is. Yep. So this is a classic instability in osteoporotic fracture, and where the supine MRI will not show you the compression, but when they stand up, they get this. And this has been now very well described. In fact, this was I had presented a paper in VIROC 15 years ago, after which people sort of got thinking, and now it's really well described that these patients have dynamic instability, and because of the Kumar phenomenon, the posterior, the whole vertebra is gone, and the posterior corner remains. So when they sit up, it sort of retropulses and causes compression. So an MRI will not show it, but a dynamic X-ray will show it. The only thing is that I don't know whether the CA cervix is a red herring or not, but anyway, when you treat this, you will also send tissue for biopsy. So.
Dr. Gupte, what's your take on this thing, such cases? Dr. Vikas Gupte? Vishal, Dr. Vishal Peshattiwar? Yes, sir. Dr. Gupte.
Samir's reading and Samir's opinion. I will follow same thing. Only thing is, question here is basically from where the neurological deficit is coming from. It's not correlating with the cervical lesion seen on MRI. So needs further investigations, and whatever Samir has said, I totally agree.
Vishal?
I agree. What Samir said, this is a dynamic instability. The only issue is that there is another compression 2 levels below. Whether this is just pure benign osteoporotic or whether there is an element of malignancy, of course, is going to be after histopathology is done. But I think this is something that you would consider fixing, taking into mind that there is another lesion 2 levels below. So this is going to be a very long posterior fusion with anterior reconstruction, which will be needed.
Sorry.
Is Priyanka around? Hello?
Yeah. Yes, I'm around.
Priyanka, would you like to do a biopsy for this case with the history of CA cervix, or should we go ahead with the
No, like as it was said earlier, at the time of surgery, we'll send the sample, but not before that. Okay. Like it requires surgery, so just do it at that time.
So if what did you do, Agnivesh, for this case?
So being extensors, planters being extensors, we would think of doing MRI of the neck, or you just leave it. Though we have a diagnosis, but would you just
we did take the axial and the cervical spine, sir. I don't have it with me right now, but they were not showing any significant compression. It was one section which was showing, but the cord was not really compressed in the cervical spine. There was enough CSF posteriorly and around to sort of leave it as such.
I think an extensor plantar is a very dubious clinical sign, especially when elicited by an orthopedic surgeon. So I would just ignore that extensor plantar, and I would say that a D11 compression can also cause it. But I think if you have no signal change at that, when you have such a clear-cut issue here in the spine, I don't think we should worry too much about the cervical. Of course, one would do an MRI before taking up this patient.
I think to further what Samir and Arvind has said, now if you see all these X-rays, the collapse is happening at L2. Okay, that's below the level of your conus. Your D11 doesn't seem to be collapsing too much. The cord compression is very, very speculative. We are just assuming that this patient is developing cord compression when she stands. But normally what Samir described is that the power should be at least grade 3 to grade 4 when the patient lies down, and the power reduces when the patient stands up. This patient has grade 2 power. So that means there has to be some evidence that the cord has at least some edema, some myelomalacia because of pressure changes. Now, nothing seems to be there on that MRI. Nothing, absolutely. There is no compression above the level of L2. And one has to be worried that, you're offering a surgery for what? You're offering the surgery for preservation of neurology. Can you guarantee this on the basis of whatever information you have so far?
Yeah, Mihir, if I may answer that,
yeah,
absolutely. I've got more than 30 cases like these who have all gone on to recover. And when you say edema and myelomalacia, I'm not sure whether it's L2 or L1, but there is no cord there to undergo myelomalacia. That would be only about T10 that you will see signal changes. So I don't think you need to see signal changes either. This is very clear cut. And as to whether the power is grade 3 or grade 4 depends on how late the patient has come. Patients wait and wait and wait. So this patient would have come after 2 months.
Dynamic. Samir, it is not clear cut. Dynamic is dynamic. Even power comes and goes in such patients.
Power
comes and goes. You just can't say categorically ऐसा ही होता है. Power comes and goes.
So one second, guys.
Below N2.
Let's ask Dr. Gabriel's opinion. Dr. Gabriel, are you still around?
Yeah. So if I totally agree with all the views so far, and then if clearly the C-spine is not the problem, I'm really thinking about there might be a dynamic kyphosis and leading to stretch myelopathy type of situation. And then in a very early paper by Vaccaro 2005, and then they talk about if the cord is being stretched for about 2 to 3 centimeter, and then they have myelopathic type of symptoms. And then if the patient, the power is really weak, and then maybe one of the tests that I would have done, maybe put him on a brace, and then the patient is keep in an erect position or a duet brace, and then the patient, the power is still is good, and then with that, then I would probably confirm that the kyphosis is the cause of the problem. And if that is not the cause of the problem, and then if the patient have good power, but the reason why it's unsteady, so-called unsteady, is because of loss of proprioception, then I will go back to the C-spine.
Okay, let's proceed, Agnivesh. What did you do for this case?
Okay, so we'll just go through. So this was the CT scan, and it was showing sclerosis and all. So this is the order in which we did certain investigations. We did a PET CT, involved the oncologist to rule out because there was a previous history of CA. So the PET CT came negative for any metastasis. Myeloma profile was sent, which was negative. DEXA scan showed severe osteoporosis with spine T-score of -4.6, and in certain wrist areas and hip, it was going below -5.5 as well. And as the patient was bedridden, we did a venous Doppler and found that the patient has a DVT, which was active. It was not a chronic organized DVT. She also had significant post-void residual urine. And in discussion with our neurologist, we did something to prove that the problem is coming from there. So what we did was we did a baseline SSEP in lying down position, and then we made the patient sit for half an hour and then repeated the SSEP, which showed there was a delay in latency in the lower limb. So that sort of gave us another insight that yes, it is coming from the lower spine only. The upper one or any other is not the culprit in this case. Now, my question is that with a T-score of -5, -5.5, how do you look at this case now?
No, I think with the evolving neurology, this T-score just means that you have to take extra precautions for the screws. But if the neurology has been evolving, you still have to offer a surgery. You can start this patient on teriparatide, and if it is negative for metastasis, then you can start the patient on teriparatide simultaneously, but you still have to offer a surgery if there is conclusive evidence that it's a dynamic instability.
Yeah, Amit, if I may add.
Yes, Satyen.
This is quite complicated with the degree of osteoporosis. You will have to think about, whether pedicle screws are going to hold, whether you want to use cement, whether you want to go for heart shield. Even anterior reconstruction could be very tricky if are you just going to inject some cement in, or do you want to put a cage in? If you do that, you will have to destabilize further. It may even be worthwhile to just fix it from the back without doing any decompression in this case to keep the posterior elements intact. So it's not just fix it and forget it types.
My feeling is, most of the patients they don't actually require any active decompression. It's a kind of dynamic instability. Stabilizing them is going to be more than enough to give you kind of stable kind of spine there. Number one. Number two, whenever you fix them, you surely have to augment them. Even if the osteoporosis was only -3, I would surely still want to augment them either by adding wires and having higher anchor points, more anchor points, thicker screws. And augmentation can of course be done with various kinds. You can use either cement augmented screw, HA coated screws, or wires. But all the principles will have to be taken into account. And like Dr. Mihir said, surgery is surely not avoidable in these situations. You cannot really allow the neurology to evolve from here. So 1, surgery, yes. 2, long fixation. 3, may not really require decompression unless there is a retropulse fragment there, and augment your fixation points there. Of course, medical management is the key. In long run, you'll have to continue doing that as well.
So what I would do for this patient would be, I would do a heart shield for sure. So I would do a heart shield with 3 or 4 levels below. It's L1. I know it is, but then neurology is more important than anything else. And obviously do 4 levels above the upper one, which is T11. So 4 above and 4 below, 3 or 4 below, depending on the hold of the wires. What I do in terms of decompression is, I will never ever touch the midline. What I do is I do a transpedicular approach from one side, and I see whether the retropulse fragment is free from the cord. And what I then do is, depending on the anterior void, because there is a void, I either just pack it with bone graft with a funnel, or I do something what the name which these people, my fellows have given it a name of cage plasty, where I put in a cage in the vertebra. So the cage is only from the upper end plate to the lower end plate of the same vertebra, which props up that thing and pack it with bone graft. So that's what reconstitutes the anterior column. And I will never touch the opposite side facet and the midline. It's all entirely from one side.
Agree.
I've been doing this for many cases now.
Take the pedicle down.
Further,
Don't take the pedicle down. Use all the pedicles, even the fractured pedicle also, the fractured vertebral body also. You can use your screw there after packing it.
But I'm doing heart shield, no?
But Dr. Dalvi, putting the cage in from one side, you're still destabilizing it further, no? From one side.
Agreed, but I'm giving it anterior support. And so you need to give some. I think you need to give anterior support, otherwise it will collapse. Or then you do a vertebroplasty. Then you just do a vertebroplasty there if you want. You can do that as well.
And putting in your heart shield, you don't need to take down the midline structures at all while putting your.
My concern, just 1 second. My concern about vertebroplasty is that if the if the shell is not intact, then the cement leak is very high. So that's why I prefer not to do vertebroplasty for these patients once they have a neurological deficit. And plus, we are still not 100% sure that this is, of course, he has done a PET, so probably it's not a CS cervix. But I think, the plan which I told is the one which I would do. And yes, to put heart shield, of course, you have to take the interspinous ligaments off, of course, but not at that level. So I'll go above and below, right? So not at that level.
Shall we proceed? I think you want to show Agnivesh what you did?
Yeah. So what we did was, because there was an acute DVT, the cardiologist put a IVC filter in the patient, and the next day she was taken for surgery. We did something like this. We did cement augmented screws at multiple levels, and we did vertebroplasty of the 2 levels. This was done, and then post-operatively, patient was started on teriparatide. Physiotherapy was started and switched to clean intermittent catheterization. 3 weeks later, this IVC filter was removed, and it showed that there were multiple emboli which had gone, which this filter had trapped in itself. So luckily, she was saved. This would not have caused a life risk, but probably some breathlessness and other would have happened because of this embolism. And 3 months down the line, she's still holding on, and we are following her up closely.
Neurology is better?
Sir, she's better. She has started to walk. The power has improved now to grade 3 to 4. She's walking in the home with walker at least 25-30 steps every day now.
So Agnivesh, just one question. Why was the decision of removing the filter taken at 3 weeks post-op? Why so early? Because the patient has to be on anticoagulants for a sufficient amount of time, 3 to 4 weeks after you have stopped the anticoagulants. Then you can go in and remove the IVC filter.
Yes. So my main perioperatively, I did not want to give Flexin and all in therapeutic dose to avoid an embolism. Reason being that I did not want, with such a lot of complications, she was on immunosuppressants for ILD also initially. So I did not want to take a wound, hematoma and all that risk for the fear of infection. So the problem is that if you keep the IVC filter more than 6 weeks, it becomes difficult to retrieve because these are temporary IVC filters. So they sort of get incorporated into the vein wall, and then it becomes very difficult to retrieve them. So they have to be removed at 3 to 6 weeks. 2 weeks down the line, we started her on anticoagulation. We continued Flexane for 4 weeks, and then now she's on anticoagulants. Like she has been given the proper oral therapeutic anticoagulation for preventing the further DVT.
Agnivesh, any decompression done at the site of the pathology? L1?
No, sir. This was all indirect. This was all indirect decompression.
Okay.
Agnivesh, nicely done. The only thing I would probably add was, as Vishal said, probably put in screws at the same level as well, where you have just done a vertebroplasty, and probably augment the ends with a wire. The way I would do it is augment, same what you
True
did,
that.
put it,
True
put
that.
screws there, and proximally add wires to that, proximally and distally wires to that, just
True
at
that.
one level.
Yeah, because if you just see the preoperative, the MRI, the
Kyphosis
MRI which is
element.
very the adjacent level is also showing some sort of changes on the MRI. So probably we need to go longer up.
Yeah,
Nicely
maybe,
done.
but those we studied, those they were all marrow edemas, or they were not fractures or anything. So that's why we chose not to augment. But yes, that could have been done. I agree to that. The wires could have been put in addition.
Yes, Neeraj.
Can I add one point?
Yes, sir.
Yeah. See, as Samir rightly told, the cause of deficit here was, the instability. But regarding this fixation, actually, I have seen 3 cases where along with the cement, the implant has come out, and in fact, it has led to deficit. So in osteoporotic bone, though we are going to treat these patients medically, the soft fixation is better. The rigid fixation is not that good. And instead of putting these material, if you put a bone, which, I'm talking about the long-term outcome. So long-term outcome about the hybrid fixation and constituting the anterior column with the bone is having a good outcome, a long-term I'm talking about. So this is a matter of caution.
Sir, I agree that the one reason why we did not do that we were still not sure about whether it has got some metastatic component into there or not. That's why I did not want to put a bone graft over there, and not a cage also, because we did not know if it is metastasis, what is it, cervix, or is it something else also. So that's why we chose to put cement. But yes, heart shield is an option, and I had counseled this patient that if this fails, then the heart shield is the only option as a rescue later on, because for the time being we have done this. If this fails, then heart shield is the only rescue option. We had kept it as a backup option after the.
Even with the heart shield, the contouring should be under contoured. In the sense, rather means I would say that don't try to correct it. If you don't correct it, the chances of pull out is less. Okay, and even the hybrid fixation can be done where you can put the pedicular screw lower down and heart shield sublaminar wire
upper one.
Also.
Yes, sir.
So you have done it nicely. Thank you.
Thank you, Agnivesh. Let's move to the next case. Ayush, are you ready? Thank you, Ayush. Please proceed.
Ayush?
Ayush, we can't hear you. You need to go one slide back and please unmute yourself.
Yeah.
Please
Am I
unmute.
audible now?
Yes.
You can see the screen, I guess?
Yes, please go on.
Yeah. So he was a 32-year-old male. He presented with neck pain since 2 weeks with burning. He had a history of significant trauma. He fell from the stairs 2 weeks back. So this is the X-ray, and you can definitely see there's some amount of translation of C2 over C3, and the angle is around 18.4 degree. And so this was the neurology. Left side, he had more sort of weakness. Right was almost normal. Some weakness we could feel in the low C8T1. His Hoffman was positive on both the hands, and reflexes were exaggerated, and the lower limb was completely intact. So this is a CT scan. If you can see, there is it looks like a typical hangman with the fracture on one side. The fracture is through the body, as you can see here, and on the other side, it is through the pars. And there is a big defect out here as well. This is the MRI, and this is the fracture, which we felt on the left side is what is causing the problem. And even on the posterior, there is a small breach in the posterior element, which we could pick it on the MRI. And these are the flexion extension view. Again, if you see on the flexion of both the translation and the angle is increasing to 23.5 degree. And on extension, it is slightly correcting. These are the CT cuts on the right and the left. And on the right side, you can see this is the fracture, the pars fracture. On the left side, we had a high riding vertebral artery. So it brings back to the questions, what to do with the patient. Anyone for conservative, and if you want to operate in view of the findings, whether to go anterior or posterior.
Can you go back to the CT scan, please?
Yeah.
I really doubt, are you the neurology? I mean, are you really sure that the neurology is from this?
You have mid-sagittal, mid-sagittal CT, like a CT which looks like an X-ray. You have no.
No, we don't have that. I don't have not put it here. So this is the thing when you flexion extension. This is the one. This fragment is the one which is in the weakness. Definitely the left, right. Okay, it's almost normal. The left hand was definitely weak for sure, as I put it on the neurology. And we felt this when in flexing extension, the fragment, the posterior fragment, which is the one which is compressing the cortex. And this is of course.
How old? How old is this injury?
2 weeks old.
Kshitij around? Kshitij?
Yeah, so I would say that if I may answer.
Please, sir. Please proceed.
Yeah. So I would say that in this sort of an injury, it is the sort of moment of trauma and the instability which is the cause of deficit rather than the compression. And I would not, get too distracted by that so-called fragment. What I would, it's very brave to take a flexion extension X-ray. I would never dream of taking one. But what I would do is, and this patient seems to have an anterior cord syndrome because he's got upper limbs involved and lower limbs seem to be normal. So provided, there is no other injury, because sometimes they have brachial plexus injuries also. I would do a reduction and posterior surgery for this patient. And if I was good at putting C1 screws, then I would do a C1 to C3 posterior fixation. I wouldn't think of putting anything into that C2, maybe just a short Pawar screw to get a hold on the posterior element. And after that, I would still protect the patient. So that's what my plan is. If you're not good at putting C1 screws, then you just need to fix the occiput in that case. Then you do a long occipitocervical, OC3 or OC4. But if you're good at putting C1 screws, then you can do C1.
Amit, I want to comment.
Why not just C2-3?
C2? Sorry, no, from the posterior approach, I would span it. From the anterior up, if we plan to go anterior for a hangman, which is just a pure disc disruption, then you can do just a C2-3. But if you do posterior, if you're doing a posterior, then it is not easy for you to get a fix on C2, because the fix which you get on the Pawars, that Pawars is separated from the rest of C2. So, that C2 pedicle is fractured. So I don't think you're getting a hold on C2 when you go from the back.
Right.
So therefore you need to span it.
I think he has a occipital artery.
Dr. Sameer, I would beg to differ on that. I have a series of cases where we have done only C2, C3 fixation for these atypical hangman fractures with mild translation up to grade 1. And it really, believe me, it is not at all difficult from a regular conventional C2 Pawar screw there. And you can easily get a big, good solid hold into the C2 body right from the C2 lamina there. Like you put in a transarticular or a C2 Pawar screw, you don't go into the C1, you just go into the vertebral body there. It really gives you a good solid hold there.
So
only
the question
C2,
is that
C3 my plan.
Just 1 second. You need to then, in that case, you need to get a perfect reduction, a hairline reduction of that fracture.
Vishal, what?
Yes.
Vishal, Neeraj here. So what you are talking is a very difficult, technically difficult surgery to pass a lag screw across the fracture and taking hold into the anterior cortex and reducing everything at the end, just for avoiding one level above. Okay, but in this case, I have to comment that this is a typical stars variant, and it is unstable as per the definition, since it is 3 mm displaced. There is a kyphosis also there. And in such with a neurology, so this is a cases definitely for surgery. It is delayed by definition since it is more than 2 weeks old, and we have done 4 cases of similar type, and in which we have preferred a high cervical approach doing anterior C2 C3 fusion. So there is an advantage of avoiding C1 fixation in such cases and preventing rotation.
So Neeraj, just to take it forward. In atypical hangman's fracture with a large chunk on one side, doing an anterior surgery can sometimes be disastrous, because the cage footprint, the body may not have that footprint on the C2 base. So one should be really cautious about not only the placement of the cage, The second thing is getting a plate contoured to the odontoid, because your screw is now going to be sitting on a tiny odontoid, not the C2 body. It is going to be sitting on the tiny C2 odontoid, and sometimes the narrowest plates will not get a hold into the C2 odontoid process. Number 2. And number 3, the most important aspect is that while doing your discectomy, sometimes you may lead the fragment behind as a completely loose fragment, which you will never be able to hold with your screw there. So one, in an atypical hangman's fracture which is displaced, we really vary about using an anterior approach for all the reasons that I mentioned. Coming to the posterior part of it, believe me, it is not at all technically difficult to put in a C2 screw from the posterior laminar part into the C2 body, and it doesn't require any lag screw effect. It is as simple and as usual as you do any C2 part screws. And I have done at least 10 cases of atypical hangman's fracture doing in the same manner. Probably given a chance at the end of the session, I'll show you one or two cases.
I know, I mean, you've done it very well, but have you noticed that there may be an aberrant vertebral artery at C2 lamina here? If you see that,
there is.
Yeah.
So and Vishal, I think that the C2 body is not an issue in this unless the fracture is going into the facets on either side. You get sufficient amount of space on the C2 body to put in your plate. The most important thing, as Samir said, is that once you do a disc release, if you don't put in a cage, you can put in a graft over there, which is more forgiving than a cage. But if you get a good reduction, then that will basically save you from going to the C1, and you can get away with a big C2 pedicle screw rather than only a par screw. So I think getting
Sandeep, in anterior, as I said, in interior, it is like in a lytic spondylolisthesis doing a ALIF. It is very similar to that. And swan neck deformity is known to happen in these patients where the C2 tends to subside over the C3 and resulting into a swan neck deformity at the CV junction.
There is no doubt that this needs an anterior one because there's a significant damage to the C2 C3 disc.
Yes.
But once, and it's not very old, it's 2 weeks old. So once you release the release on traction, it's going to correct and you can have a good anatomical reduction.
Do you have an X-ray right now?
No, but guys,
you have an X-ray right now. Which
why are we just fixed on only posterior and only anterior? Why not do a good posterior and a good anterior?
So that's what this needs a circumferential.
So it needs a circumferential.
This needs a circumferential.
No, it doesn't need circumferential. It doesn't
do posterior.
No, I disagree.
Just posterior.
I disagree to this for 2 reasons. Why? Because you just have to stabilize this. This pars will unite. It is just a 2 weeks old fracture. It always unites. It's like a
Vishal, there's a significant disc injury.
It always unites. You know, you just bring it back. It will unite, fuse like fire. You know, it is a body fracture of C2. It is like a odontoid type 3. It is extending into pars and it always will unite. You just have to bring it back to the position and stabilize it and hold it there for a while. It will unite.
And then even if you have a doubt about your C2 lag screw holding the part of C2 body, you can put a screw in C1. There's no harm. And you can take it out after some time. You don't have to fuse C1, C2. This is a fracture surgery. You can do an implant exit easily after some time.
Kshitij, you can remove a C1 screw also later.
Yeah, that's what.
That is what I say.
Screw, just fix
exactly.
Anyway,
why are you worried?
We proceed. Shall we proceed?
So
we had all those things in mind, and this is what.
One second. Let's hear out Dr. Gabriel's opinion if he's around. Dr. Gabriel, please unmute yourself.
Thank you very much. I would probably start with posterior first, and then pedicle screw on C2, and then and C3 plus or minus whatever the large amounts of pedicle screws on one side, and then to see and then obviously intra-op tractions, and then to reduce it, and see. And then if I need to do anterior after that, then I would do anterior, and then posterior I would do fusion as well as C2-3.
So what would make you go anterior for this case after posterior fixation?
Yeah, after posterior fixation, if I realize it's not fusing well, and then if it's still subluxing or any signs of instability, that one screw on the pars one screw on the pedicle on the right side is not holding. The left side is a translaminar screw probably, and then I would do the anterior as well. Yes.
Ayush, please proceed.
Yeah. So we had all these things in mind. So of course, everything we did under neuromonitoring, we first approached the anterior, and what I preferred here is the 0P cage. The only reason I wanted to do this because then the angulation with 0P is up to 45 degree. And even the medial lateral, you can angulate up to 5 to 10 degree. So ideally, I wanted to avoid the fragment which is in the body. So this is the intraoperative picture. If you see, I have angled it away from the fragment. That will only happen if I have that that angulation with me. With a plate, I thought it will be difficult. We could reduce it up to a certain extent anteriorly, which is we felt it was decent. And then went posteriorly, and because I will, maybe Vishal can do it and he is very confident, but we didn't have that experience. So we chose a laminar screw in C2 and we did a C2, C3. So this is the 1 month follow-up and this is how it looks at 1 month. And this is the 6 months follow-up and everything, even the body and the pars defect has united. He has almost improved. Some weakness still on the left side, but he's doing well.
But your laminar screw is not holding the proximal fragment.
Yeah. Exactly, Ayush. I'm sorry, but yeah, somebody else asked it in a nicer way before I did.
Yeah.
Sorry.
So laminar screw is part of the distal fragment.
Yeah. So anteriorly we supported, but even the CT scan, if you see, there's a posterior elements are also gone. That MRI.
But if you want to protect your ACDF, you will have to do what Vishal is saying, or at least put a screw in C1.
So instead, it will add more displacing force to the fracture.
So anyway, it has united. You can say everything, but if you see this,
because of your ACDF, that's good.
I think Kshitij, one laminar screw which was holding the anterior part of the body, like the C2 body was kind of still in continuity with the C2. So I think that must have definitely added to the.
This part was okay, and there is only reach here. So with this and the posterior element, we thought with the anterior support, this is much easy to do than whatever said and done. So that was the whole plan. And there's a posterior ligaments are also gone. So we wanted to give him something posterior.
Because the pictures are not enough to judge. I thought it was a bilateral pars lysis.
No, it's not a bilateral pars. The one is through the pars and one was through the body. This was completely connected. So we
Ayush, please be remembered that hangman's fracture implies that there is a complete disruption of the posterior column. The fracture on one side runs through the pars, on the other side it runs through the body, taking the pars on the other side. So even if it is difficult of putting pars screw on one side, the other side always is easy to put in a screw to hold the body. This probably is not holding anything in the body, but the spinal CT scan, I don't know if it is a 6 month follow-up, then it already is showing the fusion that I was saying you, that it just fuses like fire. Always it fuses like fire.
I mean, if you get if you get a traction reduction, you can allow this to fuse in a halo vest.
Yes, exactly.
So that's not a big deal. These will heal. The only problem is that the ligament disruption seems to be too much. So there is always a potential that with conservative treatment, it will go in kyphosis. So it's better to do surgery.
Ayush, you could have easily gotten away with a C1 to C2, C3 fusion, the same result.
So
you tried with both surgery.
So I think Amit, we can move on now.
We could mobilize it with a Philadelphia even after a week or so.
Thank you, Ayush. Thank you, guys. So next case is by Amandeep. So before we proceed, I would request Dr. Gabriel. So if you would like to stay, he's more than welcome. But for any reason, if he wants to leave the meeting, then we'll leave it to his own discretion.
Thank you very much, guys. So maybe I'll hang on for a while, and then if this is getting very heated, after a while, I will take my leave soon. But
your opinion is actually quite important to us. So I will rather request if you could stay back.
Yes, we will request you to stay.
It is a request, our request. Thank you.
Mandeep, please.
Yeah.
Thank you.
So this case is of a 52-year-old male with acute onset early myelopathy signs since last 2 weeks, and he was showing signs of left grip weakness and clumsy gait. His modified JO score was 14/7. He had Hoffman sign positive. Lower limbs were normal. There were no bowel bladder complaints. No history of trauma. Past history, he had undergone a OC 3-4 stabilization 1 year back. And he is a known case of ankylosing spondylitis. He has diabetes, hypertension. This was his CT, X-rays, and MRI pictures at the time of the previous surgery, before the previous surgery. You can see it. We had a certain amount of atlantoaxial dislocation. The basilar invagination was not that significant. On the McRae sign, it was around 0. It was just touching it. And C1 arch excision was done by the primary surgeon, and O occiput to C3, C4 fusion was done. Now, 6 months post the index surgery, he developed implant failure. You can see the occiput screws are backed out, and there is some zone of lysis around the Lapar screws as well. Now, at time of presentation to us, this was a CT and MRI images. He had a significant amount of basilar invagination. He had a stenosis at OC1 joint at the foramen magnum. The clivus angle was around 133 degrees. The dens was retroverted, and there was a proper misalignment of the cervico-medullary junction as well. Now, these are other investigations or parameters, the clinical radiological parameters of this patient. And from the joint perspective, the sagittal inclination of the C1, C2 joint, you can see it's almost vertical. On the right side, it is 70 degrees, 170 degrees. On the left, it is 165. And we got a angiography also done. He had a high riding vertebral artery on the left side and hypoplastic powers, C2 powers on both the sides. The course of the artery was normal. Should I go ahead? Hello.
I guess finish with the clinical. Yeah. What do you want to finish with the clinical presentation?
Clinical presentation wise, he had a short neck, mouth opening was restricted. Movements, neck movements, he only had a certain jog movements of about 5 to 10 degrees. So at this junction, we'll have to plan for treatment. Certainly, roll for traction with a implant in C2, I don't think there's any roll for traction in this patient. Surgical approach, whether anterior plus posterior, only posterior. Should we excise the odontoid, and any scope for a transnasal endoscopy? Yeah.
Can I?
Yes, Srivastava, sir, please.
In this case, to make everything very easy, it should be done first. We expose posteriorly, take out the implant, give traction intra-op, and see how much is your vesicular invagination which is coming down. If the first, the span between the first surgery and failure is not too much, in that case, you might find that since the patient is under anesthesia, it might come down because it had come down. There is a possibility of fusion which was attempted earlier, might have been attempted earlier. So that might be a questionable thing, whether it is going to come down or not. Suppose in case you find that it is not coming down, in that case, you close down and then you can give traction at later date, means once the patient is reversed, you go ahead, give traction to keep the patient in the ward maybe for a few days, and then you again come, we do anterior surgery. In this case, this is the case where there is an indication of retropharyngeal release. And because you are not going to go through the oral route. So in that case, it is possible that you retract that and you are able to do the anterior release, and you just assess whether you are able to reduce it. If it brings, the whole this exercise, it brings it down, then you go posterior. Now we are aware that the screw on the occiput had come out. So in this case, the lower screws which were there in the lateral mass can neutralize, and the upper part where we can just make a loop-like thing and we can fix with the sublaminar wire, because I have done in some cases and it holds very well, because you are not going to have one deploy or bi-deploy fixation, because you can make an opening in the different area and you can pass the sublaminar wire. And then the main question is how you are going to actually reconstruct the lateral pillar, because if we don't fuse the lateral pillar, in that case there will be again failure in this case, because again it will go into kyphosis at a later date. So whatever the available surface is there, it means whatever bone in the suture area is there, and between the occiput, that has to be fused with the rectangular graft there. So I will not be preferring to put any case there. I know the actually joint has become vertical, but whatever correction we get after release, then we can put a bone graft there and just see the outcome. I think that should be the procedure which I will plan, and my aim for all this surgery will be to bring the dents down and correct the clivus canal angle. These are the only two purposes, and the always back of mind, fuse it nicely with a good amount of bone graft.
Can I add something to what Amandeep has said? Sir, the problem here is that the patient is 110 kilos. There is a huge lipomatous tissue here. The chin is like this. Retropharyngeal approach is not possible. Transoral is not possible. The clivus has gone way ahead. So doing an anterior release you look at his structure, doing an anterior release is probably contraindicated. You cannot stretch him out. He doesn't stretch out. He's ankylosing spondylitis. His neck is stiff. He is a congenital 160-degree inclination, which is probably the worst combination. A stiff neck, a fixed kyphosis, and a huge morbid patient is a contraindication for an anterior surgery.
So, Dr. Mihir, I think the very fact that the implant has failed after a primary surgery and the cranium has subsided on the C2, I think this in itself proves the testimony that that particular segment is still mobile. It is not a fixed segment. Number one.
Yeah, if you see there is no hold on the C1, C2.
Very true. So that's what I'm trying to prove, Dr. Mihir. That's what exactly I'm trying to prove. That since the implant has failed, it's a frank pseudoarthrosis, and that particular C1, C2 joint junction that has happened, the pseudoarthrosis that's happening there, is a testimony that it is still mobile. Now, I don't mean to say mobile means it is going to completely reduce by itself, but I think there is definitely a role of preoperative traction and intraoperative joint jamming and distraction, like a pucca technique to just bring the C1 back on C2, and if required, putting in a cage there.
So can I speak?
Yes, sir, please go
His neck is looking like this because implant is still there. The moment you believe me, the moment you remove the implant, this is going to improve. And that's why I myself talk about taking out the implant, closing it down again, and then go ahead and put the patient on traction. It will improve.
Can I add something?
Yeah.
Over here? I think I would agree with SK sir, because it's not very difficult in this approach. In fact, retropharyngeal is the approach where you can, this is ideally made for a retropharyngeal approach. There's no other anterior approach that you can employ in this case. And whatever you do, in this case, if you see, there is dysplasia of the joints, but also there's erosion of the joint. So probably just a release might not be enough in this case. The second thing is that your aim of surgery should be correction of the cervicomedullary angle and correction of kyphosis, and not aim to get the whole thing down. I doubt whether you will get an anatomical reduction in this. We have had one such case in which the odontoid still stays above the clivus, and the patient has recovered. So the aim should be restoration of the cervicomedullary angle and correction of the kyphosis.
Now, in this case, if you'll see, the sagittal inclination angles of C1, C2 was almost vertical. So on a vertical joint cannot bear the forces of stabilizing the skull on the cervical spine. So the kyphosis would keep on increasing. So I think the basis of surgery or your main aim should be to have a load bearing kind of a joint, not a load sharing thing. So with that in mind, we had some technical difficulties as well with we were planning for the surgery. Now from the anterior release point, because of a short and stubby neck, we weren't too sure whether we'll get a proper soft tissue release or whether it would be possible or not. As SK sir also said, that doing a transoral with restricted movement joint mouth opening is not possible. With an ankylosing spondylitis, there is neck mobility is not too sure, and the C1, C2 joint is almost ankylosed. Now, transnasal, we don't have too much experience in it, so we didn't give it that much of a thought as well. There were technical difficulties in the posterior approach as well. The C1, C2 kyphosis was more than 160 degrees. We had a narrow zone of working between the C1, between the vertebral artery, which was overlapping with the high riding vertebral artery at C2, and which was passing the C1 as well. The distance was only about 5 millimeter. He had hypoplastic C2 pass on both the sides, and there were altered anatomical landmark as the C1 arch was excised. So this is what we had planned. We planned to do a trans osteotomy kind of a thing through a trans-osseous osteotomy. We used a bone scalpel for this for reasons as it was only a 5 mm corridor, a safe corridor forward. We plan to put in a cage and create a pseudo joint in which we can just lever it outwards and correct the kyphosis a little bit. And all this was done under neuromonitoring. This is the post-operative images of the patient. We had partial reduction, as Sonone sir also saying that it is quite difficult to have a complete reduction in such patients. We did a foramen magnum decompression as well. We burred it out to open up a little bit to reduce the stenosis. And the Wickenheim-Clivus line, which was earlier 36, now it is 26. So we were able to pull it down by about a centimeter or so. And the stenosis, which was around 7 millimeter, we were able to open it till 15 millimeter. And this is the final improvement in radiological parameters. Yeah.
You have a post-operative MRI?
How is the patient clinically?
It's only 3 weeks. It's only 1 month post surgery now, so we still haven't gotten an MRI done. We only have a CT scan. His gait has improved, his grip has improved, but as I said, it's only about 6 weeks post surgery, around 1 month and a half. So we still haven't done any MRIs or charted his geo scores. But clinically, he does has a improvement in his grip strength and balance as well.
I just wanted to ask, why don't we, go back to the traditional transoral in this transoral odontoidectomy in this difficult patient?
Sir, I was going through literature as well. Now there are some literatures of transoral release. So SK sir
release, odontoidectomy.
Actually, we took the opinion of the neurosurgeon. He said that the morbidity and the mortality of a transoral in an ankylosing spondylitis, high riding basilar invagination, where you have to do an extended approach to get the odontoid, the restricted mouth opening, patient has sleep apnea. Doing such kind of things transorally or any kind of anterior thing is very high risk, and you will have to the patient has probably to accept a very high degree of morbidity.
Now they do it endonasal.
Sir, and doing endonasal as well, if you'll see the level of the odontoid, it is almost above the hard palate. So it would be a hard palate splitting one. And I don't know we don't have that much experience in doing any endoscopic surgeries through endonasal.
Dr. Chandan Mohanty here.
Yeah. So can the neurosurgeons enlighten us a little bit on this approaches?
I just saw his name.
Yes, Chandan is there. Chandan is joined. Hi, Chandan.
Hi. So this one is a good case for an endonasal odontoidectomy because the thing is that it will be exactly in the line of sight. So we usually do clival tumors also through the endonasal approach. So it is much easier to do it through the nose.
Can we have Dr. Gabriel's opinion on this?
Yep.
I must congratulate you for the initial result looks very good, and then I would.
It's a good case for endonasal.
Yeah, thank you very much for showing it, and then I would probably do the same posterior approach first, and then to see what we can get, and before we would then consider any anterior decompressions, and then because of the odontoid is really migrated very high up into the foramen magnum. I'm not sure whether the traditional transoral would be able to decompress this particular area, but certainly by doing the traction I would be thinking about that, and then reposition all the screws, and then as per what you have done, and then the C1 C2 release is a very, very nice touch. and then which is very impressive. Thank you very much. One question I have for you is that how do you ensure the fusion will occur?
We have used in bone graft in such patients earlier as well. In this patient as well, we utilize a autologous graft, the posterior iliac bone graft, and we just pack it up. You can see the similar presentation. SK sir has a good paper on this, in which as well he had used the iliac graft as well. Dr. Bapat also has a similar paper on this, and that is what we are following over here.
Sure. Thank you very much.
Dr. Amandeep, I have one question for you. How do you assess your post-op reduction with respect to the pre-implant failure reduction?
Post-op reduction, I had given you the CT scan images as well. So
yeah.
I'll just
So how do you assess and compare it with when the patient did not have an implant failure? How was the atlantodense and how was the odontoid position at that time?
Initial one, if you'll see, the basilar invagination was not that significant on the Mecre line. It was just touching the Mecre line. But on the Weckenheim-Klevers line, it was crossing it. I'll just go back to that slide. Just give me a moment. Bear with me. Over here. And you can see the orientation of the joint as well. It was, to begin with, it was almost 150, 160 degrees at the initial onset as well. So I think the main reason for the implant to fail was the orientation of the joint one, and not using a bone graft for the posterior fusion as well. So before the surgery could fuse, the implant failed.
Yeah, if you see here, the odontoid is pretty down. Only, I think, as you rightly said, maybe the joint orientation was the reason for this.
Yeah.
Would you put him on halo for protection?
We have only given him a cervical collar, and I think that is quite good enough for halo vest and all. With the Indian environment, it becomes quite cumbersome for the patient as well. The atmosphere and all, humidity and all.
Srivastava sir, last word, and then we'll move to the next case.
So here again, when we are able to align it, whatever possible way is there, there is a space in this area always. So even if little bit of the sagittal shift will be tolerated nicely by that, the area is very capacious, so cord will not have much problem. Main thing here is the fusion. One should take extra pain to fuse from C2, C3 to occiput. So there the burring of the occiput is extremely important. You should have a punctate bleeding from the occipital bone. It is a cortical-like bone. So you should have that feeling that yes, it started having ooze there. So this is a good osteogenic bed. And you put a copious amount of graft there. And the iliac crest graft we have been regularly using. And you can see in CT, which is taken after maybe 6 months or 1 year, you find there's a confluent blown from the cervical area to occipital area. So the fusion is going to really protect and that is going to give the good long-lasting outcome.
Thank you, sir. Thank you, Amandeep. We are moving on to our next case. Manish, please proceed. Manish Kothari.
Yeah, hello everyone. Just sharing the slide. Is my slides visible?
Yep.
Yeah. Okay. I'll just quickly present. Good evening to everyone. So this was a 66-year-old female with a sudden onset back pain since last 5 days. It was gradually progressive, which had become very severe, could not even sit. At presentation, her VAS score for back pain was 8/10. There was no leg pain at presentation, and she had one episode of fever about 2 days ago and no fever after that. She's a known case of diabetes, hypertension. She had a chronic kidney disease with creat of 3.2, but not on dialysis. She had a history of ischemic heart disease, but no stents. And she had recently returned from a northern part of India after visiting her mother who was suffering from pneumonia. Examination on admission, her general condition was within normal limits. Her vitals were stable except there was some mild tachycardia. She had difficulty sitting, standing, even rolling on the bed was difficult for her. There was diffuse tenderness over the lumbar spine. SLR bilaterally was at positive at 60 degrees. Femoral nerve could not be tested for tension signs, and neurology was within normal limits. We just sent some quick bloods. Hemoglobin was on the lower side. Total counts were raised with neutrophilia. Platelets were okay. Creat had slightly raised from 3.2 or earlier. We had not sent CRP, ESR, or procalcitonin at this point of time. The patient was sent for a MRI and X-rays. Now this is where the drama began. She started developing neurological deficit after admission. So patient was admitted on a Sunday at around 12 noon. Patient was sent to X-rays by 2 p.m. and returned by 3 p.m. By the time she was back, I got a call from the resident saying she's complaining of numbness in the left leg. By 6 p.m., the left L2 and L3 had one loss of 1 grade by 4/5. Rest of the neurology was normal. We kept her on hourly neurological charting. We were waiting for the MRI images to come. By 6 p.m., her left lower limb had gone down to 3/5, and with some new sensory loss in the left lower limb. I examined her myself at this point of time, and there was no clear sensory level. Reflexes were globally depressed. There were no upper motor neuron signs, and plantars were bilaterally mute. She was catheterized because of she was unable to go to the washroom, and the catheter tug, the bulbocavernous, was present, so there was no loss of sacrum. These are the MRI images when they came. So there was this L3, L4 spondylodiscitis. I don't know if you can appreciate, I've zoomed in here. There's an epidural abscess extending from D6 to upper part of D9. And there's bilateral psoas abscess. So given this picture, you got X-rays done as well. X-rays are not the best of quality, but nothing significant except there is collapse of the L3-4 disc and probably some lateral instability. These were supine X-rays. We could not sit, so we don't have any loading X-rays. So now the whole lot of questions started. What is the cause of neurological deficit? Is it the epidural abscess at thoracic level, or is it the unstable L3-4 level? Or is this actually a vascular event? So a lot of questions, and what to do next was the obvious question. She's a multiply comorbid patient with kidney disease, heart disease, diabetes, and having a progressive neurology. So at this point of time, should I repeat an MRI? What if she deteriorates further while she's gone for an MRI? This was in a peripheral center, not in a tertiary center. So getting an MRI done itself would take about 4 or 5 hours and back. So going back to the MRI, yeah, would anyone like to comment, or should I proceed?
Vishal Peshettivar, are you there?
I would have liked to see some axial cuts at the dorsal level, actually.
Yes, I'm here.
Sorry, yeah. So it's just that segment. I don't have them, I'm sorry. But it's just that posterior epidural segment. Yeah, from D6 to D9.
And what is the neurology like? Is it upper motor neuron, lower motor neuron? And what?
It is flaccid, sir.
But what are the levels? Just see, the hips are involved.
Hips are involved. So L2 and L3 is 4/5 by 6 p.m. And she's gradually worsening. It becomes 3/5 later on.
At least so showing some. There is an epidural abscess.
Yeah, I would say that, see, you need to really study axials to see what's happening. But if the axials at because see that one mid-sagittal cut gives you no information. If the axials at that level D7, D8, D9 is showing you a circumferential epidural abscess, you should just take her up immediately for a decompression at that level, because these patients once they become total, they never ever recover. So and these are pyogenic infections. So the pyogenic infections they progress very rapidly. So you don't worry about L3-4. I mean, L3-4 is the cause of a backache, not the cause of a deficit. So what you need to, so that you can treat later on as well, that can be treated with antibiotics. But what you need is not give antibiotics, take up the patient immediately, do a decompression, get tissue, and then start on antibiotics and wait for the cultures and start on appropriate antibiotics. So I think that's the best thing. But because once they become total, they don't recover. So you need to do that.
But there are both the levels. Why can't they handle both together? There is this D7 to D9 posterior epidural abscess, and then from L2 to L4 there is the epidural abscess which is volar to the dural sac.
No, that's what I don't know. He needs to show me axials. You see, that's what I'm saying. This one mid-sagittal image doesn't.
There was a clear abscess at the thoracic level. Unfortunately, I don't have the axials. This is the lumbar axial at L3.
So this lumbar, what we are seeing in front, we don't know whether that is a abscess or not. So we need to actually see that, and I don't know, because she's a CRF, they must not have given contrast. But you know, yeah, but at the same time, we need to just have a look at. So honestly, in Hinduja, we would also give contrast, because if she's on dialysis, but she's not on dialysis, right? If she's on dialysis, you can also give contrast. But even without contrast, I think it's very, very important. So to me, the axials are the most important determinant. Axials plus clinical neurological status, the neurological level.
Right, sir.
So if she's proximal to L3-4, unless and until that abscess has really gone up, then you'll have to tackle both as.
No, I think there is a sure shot abscess behind the L2 vertebral body. This cut is at L3-4 disc level, where the abscess molar is not seen, whereas the abscess, which is posterior retrovertebral at L2 body, is not seen. There is no cut at that level. There is a definite abscess.
Yeah, we need to see. That's what I'm saying. We need to study. And if both are bad, if both are compressing significantly, both need to be treated.
So this was not compressive. There was some doubt at L2, as Dr. Vishal pointed out. We didn't have contrast.
Can I?
We didn't have contrast.
Can
Yes,
I say something?
Yes.
See, Vishal is saying that it's an abscess behind L2. I'm not sure. It's a thickening of the meninges. Have you taken a neurology opinion whether it's a meningitis?
So this was Sunday evening, sir. So, and she was deteriorating quickly.
No, the thing is that, see, you have a dorsal abscess which doesn't appear compressive. So that doesn't explain the neurology. You have an L3-4 lesion with a neurology which is proximal to it, which is not explained by your dorsal lesion. So there is something else happening as well.
Yes, sir.
So
exactly.
Unless you really get into all these things, you should not touch this patient.
I take your point, sir, but she was deteriorating rapidly, and epidural abscesses can progress. Although this was at 2 p.m. MRI, they can progress rapidly.
No, but if it is progressing because of meningitis, then what?
So
one other doubt. Manish, can I ask a doubt?
Yeah, please.
Manish, if you see the sagittal, the consistency over here, it's as good as the CSF consistency. So is it like 100% an abscess, or it could be something else which you are now reading into it? Like if you see the consistency here and here, it's totally different. The dorsal level is giving a CSF like consistency, whereas the lumbar is giving an abscess like consistency. So that was a doubt that I had.
So this is clearly an abscess. This is a hyperacute abscess which will appear bright on T2. So this is clearly an abscess. There is no doubt. The thoracic level. Lumbar, this is clearly discitis.
Yeah.
Bilateral. Axial also shows abscess. Bilateral psoas abscess.
Yeah.
The thing is, the neurology is not matching. So I was wondering whether this thoracic has actually kind of increased, because this is purulent bacterial. They progress quite rapidly. So should I proceed? Right?
Yeah. Here, can I make one point?
Yes.
See what Mihir has mentioned now. You try to see the center also. What he was referring to, myelitis and arachnoiditis, that is one of the very important cases. Your history was so superb that she came, the relative was having pneumonia, fever. So from there she might have got the organism, and such a rapid deterioration, it leads to some direction apart from sending the blood culture and all those things. But what about why she has deteriorated rapidly? Because if you see the sagittal cut, you don't find so much the acute compression. You might have seen the axial cut, definitely, I am sure.
Yes,
and that's why you are convinced that this was the cause, because sometime in mid sagittal cut you don't see much, but the moment you see the axial cuts, that's why Samir was stressing about the axial cut. So from one side you have significant compression, so that might happen. But here the intensity of the cord, if you see the intensity of the cord, this is not normal. Normally what cord we
in the lumbar level.
So here also it gives a different picture. Okay.
Yes.
So that.
So I have another thing to say about this meningitis part. So I disagree that this can be meningitis. I will tell you why. Because we are dealing with an acute episode, not a chronic. A chronic tuberculous meningitis can present with deficit and this sort of an issue. But a acute meningitis will present more with meningeal signs, meningeal irritation, neck stiffness, etc., rather than neurological deficit.
I completely disagree.
Can I finish? Number two, for some reason, for an acute or even for tuberculosis, a combination of epidural with meningeal is very, very rare for some reason. If they have meningitis, they don't have extra meningeal, and if they have extra, they don't have meningeal. So it is not unheard of, but it is uncommon. So I think for an acute meningitis, acute pyogenic meningitis, presenting with a deficit is less likely. And I would really, I'm telling you, that sagittal cut gives no meaning, because how these patients have, they have a circumferential cuff. And what happens is that these people have a vascular cutoff to the cord, and that is what causes the deficit. And that is why you must operate early. Once they are total, there is no, even if they had complete deficit for half an hour, they are not going to recover, because it's a vascular episode. That the circumferential cuff has gone around, they get end arteritis of the vessels, and they get an infarct of the cord. So they don't recover. So again, I stress that axial cuts are very, very important.
Let me add, one, the deterioration is of lower motor neuron type. It is not upper motor neuron type. Secondly, it doesn't match with your dorsal lesion at all. There is no sensory level. So if the neurology has been following so rapidly, it should not be only up to L2. It should be proximal to that. Secondly, is that acute pyogenic meningitis. I have had 4 examples in CKD patients who were on dialysis. So they had lesions below, but they had acute meningitis presenting as transverse myelitis. It is not unheard of.
May I add, she had no meningeal signs, no headache, no photophobia, no neck rigidity.
No, they don't have meningeal signs. They don't have meningeal signs. Gram-negative septicemias do not present as meningeal signs. They do not present as headaches. They do not present as neck rigidities. They can present as transverse myelitis.
So I think I'll proceed ahead. I was thinking in lines of Dalvi sir, and I thought I should decompress the thoracic. Probably it's kind of increasing in size. I didn't see the point of repeating an MRI on a Sunday evening and wasting another 4 or 5 hours. And I also thought this might be a vascular event, which may explain the flaccid, no UMN signs, which is seen in acute vascular events. Yeah. So I decided to tackle both the levels at the same time. By the time the patient was taken up for surgery, this was almost midnight now. Power on L2 on the left side has almost become 0. Right was around 2/5. There was patchy loss of sensation. There was no clear sensory level even at this point of time. Reflexes were globally depressed. Frontals were mute. Hypotonia, no UMN signs. So I did a D6, 7, 8, 9 laminectomy complete. There was frank pus drain. And after the pus, I went above and below, found a normal dural layer, and CSF pulsation seen. I was quite happy with the surgery. And also I did the lumbar 1, L1 to S1 fixation, 3/4 laminectomy, and did a transpedicular, rather T-lift approach, put in autograft at L3/4. Now, just when I was about to put the rods and call it a day, this was almost around 4 a.m. now, the dural layer was a bit pale. So, but there was a frank pus all around. So I'm sure everybody must have guessed what am I hinting
It's a intradural abscess.
Yeah. So, so now just I was giving my thought process. This is again, we are tired. Is the color because of the pus which are surrounding the dura, or is it something inside? And again, the question is, how do I know? One option is I frequently use ultrasonography, but at this center there was no USG in the OT. So my concern was, should I breach the dural layer? If there is nothing inside and there is frank pus outside, I may be risking meningitis and probably even late onset arachnoiditis. So I was really in 2 doubts, in 2 minds. I asked my anesthetist to do a Valsalva maneuver. There were no CSF pulsation scenes. That made me really suspicious. And on manual palpation, it was like a boggy feel. So that almost kind of convinced me there's something going on inside. I just put a nick with a 21 gauge needle, and there was frank pus which came out. This was at L3/4 level. This is just a quick intro of video. I drained plenty of pus. So that was the amount of pus that came out, almost roughly around 50 ml. I opened up the dura furthermore and drained as much as I could. It took me almost about 30 minutes just to drain the pus from the inside the dural layer. I passed in an infant feeding tube, cranially and caudally, gave a warm saline wash. However, there was no CSF seen. I just kept on giving wash. There was no pus even further. Now the questions further was that, how do I know that I've drained all the pockets? I still don't know what is the compressive lesion. This might have caused the neurology, but there may be something intervening. I still don't know. Then should I expose the intervening levels from D12, D11 and 9? And again, if I do that or don't do that, also should I repair the dural layers or not? So I asked my anesthetist again to do a Valsalva maneuver. I don't know why I went back to that, but I could see some arachnoid pulsations and I decided to call it a day. I did not do anything further. Put in the rods and closed it. I did not close the dura as well. This immediately next morning we got an MRI done. This was the immediate post-op MRI. There's a large pseudomeningocele, obviously, and we gave a contrast as well this time, taking the risk. We talked to the nephrologist. He said you can give because it's a potentially serious condition, and there was nothing seen inside the dura at this point of time. The thoracic layer appeared all right. We did a complete infection protocol. We did our blood culture, everything. We got a neurosurgical opinion as well. The drain now started showing CSF. There was no frank pus seen in the drain. Started broad spectrum antibiotics. Patient improved by 1 grade on day 2. The first culture showed Streptococcus pneumoniae, which was intermediate resistance to penicillin G, which is why the correlation to pneumonia in the family probably held true. We started on 3 drugs, antibiotics, and also kept her on bed rest because the bones were quite osteoporotic during the surgery. We could not do, because of the COVID lockdown, we could not do follow-up imaging, but we were just doing ESR and CRP, and it normalized after 6 weeks, and we continued antibiotics for almost 4 months. This was about 8 months follow-up, and she's recovered gradually. I was really worried about post-op arachnoiditis. She may improve the neurology, but she may have persistent disabling pain. But luckily, I was lucky here that she did not have any symptoms of arachnoiditis, although MRI did show some root clumping, but no symptoms as such. So this was a very one-off case. I've never seen something like this. I've done a lot of epidurals, abscesses, but epidural, intradural with spondylolischitis was the first one for me.
Yeah. So I will share my experience. I have seen a similar case. With a tuberculosis of spine. Hence, I was suspecting this. Also on sagittal, on a sagittal MR, what you have shown prior on T2, you can see some intensity changes, which give me some suspicion of intradural abscess. Also, this is a described entity for E. coli and Staph aureus, but most commonly associated with a vertebral osteomyelitis.
Yeah, so Streptococcus pneumoniae is known to cross barriers very easily versus Staph aureus, which does not cross barriers so easily. So, yeah.
No, I think we had a pointer in your case. See, your level of lesion was not matching with your dorsal level. And that was an eye-opener. That means there was a suspicious lesion proximal in the lumbar spine. There was no compression at the level of the dorsal spine. Otherwise, your MRI guys would have flagged it. If there was a compressive lesion, always in the report, they tell you that there is a compression. So this was a
So you can see at L1, L2 level, disc level and below, there is some intradural.
So in retrospect, obviously after doing the surgery, I realized that signal is not normal.
No, if you look very closely at the conus, there is a hyperintensity in that conus.
Yes.
And the patient was evolving into a transverse myelitis. And this patient was a case of a transverse myelitis, which was evolving.
But again, sir, as a surgeon,
you can't get transverse myelitis at L2. Sorry.
L1, you see, I am saying conus, not cord. It is conus. And you can have arachnoiditis at L2, which can present as a diffuse lesion. But this patient is a case of meningitis. It's not a case of dorsal epidural abscess.
Neeraj, sir, but you can't leave the dorsal abscess like that way. Supposedly having an actual scan.
No, I am saying that, the dorsal lesion has not been studied. It has not been studied clinically. It has not been studied radiologically. So to just assume...
Dr. Gabriel, does he have any experience with these kind of lesions? Dr. Gabriel.
Amit, we can move. It is 9:15. We can, after this comment, we can move to the next case, last case.
Thank you very much for sharing. I don't have very much experience, and then in this intradural abscess. Just a question. I mean, thank you very much for sharing. You did not close the dura. Is that what you have done?
Yeah, yeah. So primarily,
Okay.
I did not close the dura.
Is that the usual practice to deal with this type of
No, no, that's
abscess?
not that was a major dilemma for me. Should I close the dura or not? Because there's an active infection outside, but there's also infection inside. And I tried my best to drain all the abscess from inside the dura. I passed in a feeding tube, caudally, cranially, and at the end of my final drainage, there was no CSF seen. So whether is it between the two layers of the dura or is it actually inside, I was not very sure. But I thought I can leave it for the time being, because if there's any further abscess, I don't want to make it a closed compartment. I want to leave the compartment open and let it drain in the drain. If need be, I can close it on day 1 or day 2. If nothing, I got a neurosurgical reference on next day to keep that option open, should I close or not. That was an active thought process. But she started draining and the neurosurgeon said it might be too friable now, so probably leave it at best. I may add that I got lucky. The pseudomeningocele resolved completely clinically. There was a swelling clinically for the first 3 months. She could not lie down and supine. By around 9 months, the pseudomeningocele has completely resolved.
May I take a poll from the experts? Those who would leave the dura open, raise your hand. So Diraj and Arvind. Okay. Thank you. Thanks.
I mean, I would say in the middle of the night also you can involve an on-call neurosurgeon.
Yeah,
share your responsibility, because it's like you're risking it.
I agree with Kshitij. This is a case that needs to be done in an institute that can handle everything. I mean, you are a great, you are gifted in doing this. The way you have done it is excellent, but it should be done in an institute. This is not to be done in a nursing place that
So
lacks.
there was, so next day there was plans to shift her, but she was doing very well and the physicians were quite confident that she'll be fine. The neurosurgeon was confident she'll be fine, so we probably let her be.
Thank you, Manish. Manish, I think we'll move on to the last case.
Thank you very much.
Very good case. Yeah.
Thanks, Manish. Ankit, are you ready to screen share?
Ankit, you should unmute yourself. Ankit.
Here is a 70-year-old male, no comorbidities as such, presented with mid-back pain, left more than right anterior thigh pain, L2 and 3 dermatomas in 3 months. The VS for back was 9 out of 10 and VS of leg was 7 out of 10. He had recent onset inability to stand and walk because of weakness. He had a past history of L4-5 decompression in 94, L3-5 TLIF in 2014, and a C5-6 ACDF in 2016. He had an old bilateral foot drop, which he was okay with and was walking. Bowel bladder was normal, and he had just recently recovered from COVID-19. So on examination, there was deep tenderness, FNST was positive. The neurology was like hip knee was weak, more on the left side. Ankle dorsiflexion was 0/5 bilaterally with atrophy of the muscles. He had sensory hypoesthesia. On the x-rays, we can see that he had a discal injury with instability and a vacuum sign at L1-2 with significant sclerosis at that level. On flexionizations and x-rays, there was some mobility and he was overall coronally as well as sedatively balanced. The L5 screw on the right side was broken. Moving on to the MRI, he had stenosis at L1-2, more on the left side. The other levels which were operated prior were decompressed well, and he had L5-1 collapsed disc space. So the dilemma here was how to go about operating. Whether to go short, like L1-2 TLIF, keep the LO23 disc mobile, like a floating fusion, add a MIS TLIF or an open TLIF, either fix L1-2, add a domino and connect to the L2-5 construct, like a long construct, go from D10 all the way to sacrum with an antibody at L5-1, or D10 to pelvis, or try to create a lumbar lordosis. And at the last, can we do an anterior surgery like L12 OLIF or L123 OLIF? These are X-rays. So
actually, that this case looks slightly odd to me. It's like so much of degeneration at a floating level, causing so much sclerosis and end plate change. I mean, nothing is impossible. I don't know. I hope it's not infection. I mean, I'm sure you operated this patient. If your question is only whether we should leave a floating segment in the middle, my answer would be no. And my answer would be that when you do the surgery and you do the TLIF and the fusion, you need to really study all the pelvic parameters and restore the lordosis accordingly, because otherwise you'll get further PJK. So that's one of the reasons why I don't like to do much fusion, because you have to think too much. But in this case, you have no choice. The L3 to L5 fusion is a bit, flat backed. And probably that's the reason why they went into this sort of excess degeneration. So you're going to have to really study, read up on pelvic parameters and how much lordosis is required to achieve for this guy. And you can't even end at L2. You may have to go higher to achieve the proper sort of sagittal profile for this patient.
Now, actually, in this case, it is very important to know what is the etiology, what is the cause because of which this has occurred. As you rightly told that he had a long-standing foot drop. So lower down is not the cause. The cause is higher up because it is matching with your neural involvement. So that area is to be addressed. And basically, in your bending film, it is not moving much. So here there should be a role of decompression. Okay. So I think I am thinking in that line that lower down, whatever is there, it is long standing. Even your foot drop is very long standing. The present situation is here because that is matching with the neurological deficit. I think that should be tackled, and neural decompression is the main answer.
How long to fuse then? Should we go to the sacrum or should we?
It is not unstable, so I will not prefer to fuse.
Ankit, can I add something in here? I think if there is a PJK, it should be happening at the immediate adjacent level. And if you see the intensity changes over there, this is skipped a level and it is happening proximally. So I wouldn't be surprised, as Samir said, that this turns out to be something different, like a infection.
The blood workup was normal and he had no other comorbidities. He had no other past history of any falls as well. So he was basically presented me directly with this presentation. He was being conserved by other doctors, and then eventually when he developed weakness in the legs and was not able to stand and walk, he presented to me.
Dr. Arvind Kulkarni?
Just an observation, Ankit.
Hello? Yeah. So you can have an ESD which is at a skipped level. It is possible. It happens quite commonly in the neck also. And the modic changes there, themselves are a sign of instability. The stenosis at that level is also a sign of instability. The facets are so small, if you decompress, you'll render it unstable. It is potentially unstable if you don't call it unstable. So you need to extend all the way up, no leaving an island disc in between. And as Samir said, respect the pelvic parameters and sort it out once and for
all. Ankit, what's happening here is that the radiological impression of that skip level is so much that everyone is focusing on it. But if you see the adjacent level,
it's got an adjacent level
that
as well.
That also is significantly stenotic. So it is a true adjacent segment disease, though the modic changes have skipped the level. So it is an adjacent segment disease. Both levels are significantly stenotic. So you cannot leave a 14 segment. You will have to fuse and you'll have to go higher up. So the question is whether you want to stop at L1 or you want to go over the dorsal-lumbar junction.
Yes. So that is what we discussed with the patient. And then since they had already got done with 3 surgeries in the past, they were like, we want a surgery which is once and for all. So
no surgery once and for all.
Which you cannot promise, Ankit.
After having a discussion with them, we decided upon going into the lower dorsal area and going to the pelvis, and this is what we did.
Let's have a discussion. I mean, our option from Dr. Gabriel. Dr. Gabriel, if he's around.
Yeah, thanks, Vishal. Yeah, I see the patient is having anterior thigh pain, is it?
Yes.
So there's the L12 and L23, and then yeah. So with the motor amplitude changes or maybe infections, I might just try to do the anterior first, slide in a cage, and then from the anterior, and then one small incision, and then put in the L12 cage. Which one is more stenotic in the L23 or L12? I'm a little bit reluctant to hit that L23 disk space because they seem to be mobile, very good disk, and things like that.
Yes.
But I'm not sure which one is is there a disk in the L12 on the left side on the cross section?
On the right side.
L12 is the affected disc, Prof.
Yeah, this is the disc on the left side, is it? Does that correspond to the anterior level of the anterior thigh pain?
Yes. So he had more pain on the left side and more weakness on the left side.
Okay, so the L23 stenosis is there for a long time already as well. So I think maybe the L12 prolapse disc is maybe a bit of a problem. So I'm thinking about whether can I decompress it, or if I cannot decompress it, I'm going to slide in a cage for indirect decompression first on the L12 and see how they respond. And then if they don't respond well, then T10 to ILAC and concentrate on correcting the L5S1, getting as high lordosis as you can. The 4-5 is already fixed already, so you can't do much about it. And then what is the pelvic incident? Is the pelvic incident 50 something or yeah, depending on what is the pelvic incident, then I try to get as much lordosis as in the L5S1 if I need to fuse a long segment fusion as possible. But I might start with the L12 left side first. Yeah, thank you.
Anyone for just anterior surgery like L12 OLIF or L123 fixation and try and save segments?
I will follow what Dr. S K sir has advised. I will just do with a tube. So that's the only difference.
No, as I think as Dr. Gabriel said that the lower lumbar spine is fixed in almost neutral or maybe a little bit of kyphosis. So unless you correct and get a little bit of lordosis lower down, your SVA is always going to remain anterior, and you cannot be sure that this will not land up in another adjacent segment. You need to get the SVA back to as close as possible to the sacrum to maybe prevent it or whatever.
I honestly don't think that, see, although like I said, I hate fusion and I try my best to avoid fusion, but in this case you're forced to do it because you have already fused it at another level. So then you have to respect, and then you can't do a small thing. You can't say I'm going to only fuse L23. At this point, you have to do that whole bloody business of pelvic incidents and blah 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 blah. You have to study all that and restore it in that way if you want this surgery to work. I mean, he's 71, but at the same time, you can't have him coming back to surgery every 2 years.
And
So
I feel the L5 screws are in the foramen bilaterally, causing the foot drop.
So the foot drop has been since surgery, is it? Since the first surgery?
Since the fusion surgery.
I suspect they are in the foramen.
Okay. So I mean, if his other neurology has come later, see, basically you tell him you're operating him for that anterior thigh pain. Don't tell him you're operating him for foot drop at all. I mean, for sure. And I think, yeah.
I have a question for Gabriel if he's around.
Yeah.
Now, in this case, because the spine has already been fused, are we really thinking of going down to the sacrum again? Because the alpha S1 has settled, all the segments above are fused. The level of your pelvis has moved upwards. So do you take your correction from there upwards, or you want to go down and fix into the sacrum again?
Thank you very much for your for asking. Looking, I really need to study the patients a little bit more. But looking at the MRI sagittal view, and then this looks like a type 2 Russell-Yulee curve. So that means the upper portion of the lordosis should not be that high, and then the inflection point should still be L23, L3, L4 type of region. But you already fixed the L3, L4 already. So the only area that you can still correct is the L5S1 to a certain extent, unless you do a PSO at L4. And then if you're going to correct the L5S1, then probably do an anterior, if you can jack it up as much as you can. Looking at the pelvic instant, eyeballing the thing, probably is about, it's not too bad actually. The pelvic instant looks like it's about 45 degrees plus or minus. So the lordosis you get, and then it's not too bad. And then if it's 71 years old, you don't need to match exactly 10 degree off, maybe 15, 17 degree off plus or minus age adjusted. So you might still be able to get away with it. Yes, okay. So you get, if you can squeeze in a large cage underneath. And the only thing that I need to know is that if when the patient is standing up, is the knee flexed or not? If the knee is flexed, then we might need to be a bit more aggressive to dial in there, because the SVA is more severe than what we're seeing at this point of time. So so for me, my approach will probably be trying to get as much L5S1 correction as much as we can in the first stage, in a kind of a leaf type of situation, jack it up as much as I can, and then we will then see how much I can get. If I can get this MRI, sagittal MRI alignment like that, and then with a jack up L5S1, I'm okay with this shape of the spine. So that's what I'm thinking at this point of time. Especially she's 71, I'm sure she's osteoporotic and things like that. Yeah.
So we also tried to get the L5S1 get distracted, but then he had a L5 screw which was broken on the right side. We could not get any hold because the pedicle was broken on the right side. So I thought I'll try and distract between L5 and S1, but that was not possible intraoperatively. So I had to leave that L5 on the right side.
Anterior or posterior?
Posterior.
Probably this one need to do anterior. You need about a 20 degree cage inside.
Okay, Ankit,
So,
final wrap up. Final wrap up, Ankit.
So we had discussed the patient about the pros and cons of the long fusion as well as the short fusion, as well as stopping at S1 or going to the pelvis. And since they were like, they want to get it done in one go, we went from D10 to pelvis. We left the L5 broken screw inside, got into the S1 and fused after doing L1. He had a relatively straight spine, so
yeah, because in this case, even if you see now, have we got much of the lordosis here? So and if you go to the dorsal spine, if you see the SVA, it has almost remained same. Okay, you go here the dorsal spine and you add this, it is almost remain same. Rather, if you go to higher up T1 T2 area, this is actually it is going forward only. So yes, you have fixed it, but we have to keep our finger crossed whether he develops later on here more proximal to it. This is the usual story which is very commonly seen in Germany, and some of the neurosurgeon they say this, he actually just decompress the root, they will go by the minimal invasive thing. Whatever instability is visible, let it be like that. It is not a clinical instability. She doesn't have pain origin from there. It is a root pain, just decompress that root. So less work and more outcome, because here I don't think we have gained much as far as the alignment is concerned.
So can I add there?
Yeah.
So in this case, if you see that the pelvic incidence and the lumbar overall alignment, the lumbar lordosis, if you see there's not too much of mismatch. In fact, if you try to overcorrect the lumbar lordosis, then again it can land up in a PJK.
Yeah.
So if you look at the overall alignment, and again, as Dr. Gabriel said, if the patient has got a hip and knee flexion deformity, then probably the SVA is not a good parameter for actually judging, because it can vary because of the pelvic retroversion.
No, actually,
so maybe this overall alignment looks quite good.
Sandeep, that is my actually point, that from the beginning, this was not a bad curve. If you even go with the MRI, the pre-operative MRI, see,
Right.
it is not that bad. It is, if you consider from here to here, it is almost same. So actually, just to create that lordosis, that is not the issue. Issue was here that her thigh pain.
Okay, excellent. I think with the permission of Ankit, nice case. Thanks all of you. With the permission of our president, we would like to wrap up, sir.
Yes, sure.
So on behalf of the whole Bombay Spine Society, we generously thank Dr. Gabriel Lu for his time and for sharing his experience with us. We were really enriched by your experience, Dr. Gabriel. Thank you so much from all of us. A big thanks to, I guess, all the members who were presenting the cases and all the members who participated. Those who have missed out this time will make an effort to accommodate them next time on a priority basis. And I guess we call it a day. Thank you, all of you. Thanks my co-organizers as well, Dr. Sandeep and Dr. Amit. So we see you. Good night.
Good night.
Thank you so much. Thank you,
Thank
Dr.
you very
Gabriel.
much.
Good night, good night, guys.
Thanks to
Thank
all.
you. Bye.
Thank
you.
you.
Hope all of you have beers.
I have
Dr.
mine.
Gabriel sure needs one.
Yeah,
Manish, you have shown very good case.
Manish,
All
you're
great cases.
very brave. Huh? I would have never
Yeah, I would
bothered
have-
with the Dura.
I would have probably just stopped at the
There is
decompression.
frank pus inside, sir. Frank pus, the dural.
So the Dura appears very unique and pale in this case.
So does all
the
the
DB case, what I
infection.
have seen, also was looking very pale as compared to the other Dura. So I was
Manish,
also intended to open the Dura.
I guess, Manish, you don't believe in antibiotic doing their work. You had to do everything at one go.
Now, frank pus, how is antibiotic going to take care? It is
कुछ तो रुकना था, कुछ तो रखना था.
She may improve from the infection, but she may not improve from the neurological deficit.
No, the dorsal probably yes.
Absolutely right. And I think now, if you see any case, this case will remind you.
Sir, it was a very terrifying case for me.
But very, very nicely done. So
Okay, guys.
thanks to all of
Thank
you. You have participated.
Thank you,
very
everyone.
nicely.
Thank you very much. Thank you.
ऐसा भी होता
Vishal.
है, इसमें डाल सकते हैं इसमें, ऐसा भी होता है.
So tomorrow, all of us should be there.
Yes, sir.
Yeah.
Good night, guys.
Good night.